My name is Bethany Scherer. I am the Senior Director in State Advocacy at Pharma, and Pharma represents the country's leading innovative biopharmaceutical research companies. Pharma has a patient-centered agenda that is dedicated to ensuring broad patient access to safe and effective medicines. We are fighting for solutions to ensure patients can access and afford medicines that prevent, treat, and cure disease. I want to thank Georgia Bio for letting us sponsor this event today, and I look forward to learning from many of you during the panels.
And thank you to Pharma for supporting this event. As everyone knows, putting off events does cost money. The food that looks absolutely delicious that I'm about to have does take a little bit of money. And of course, our AV team with Chat with Leaders Media, thank you for helping us out today. I would also like to thank our North Fulton Chamber for hosting us as a sponsor as well, and Grail, another one of our sponsors for today. And then finally, my team who is scattered about, I sent one out to get some lemonade. So apologies, there's just water for now, but we are getting some extra drinks in here. And of course, our patients who have been our partners for many years. And you'll hear from some of our patient innovation panel and some other groups today. And we're looking forward as an organization to really elevate those voices. Throughout the program today, you might see some people get pulled out to record a small video. We're taking some patient testimonials because we're going to be building a resource page, number of pages on our website to help support patients as they understand how they can advocate for themselves and others. So just know if someone steps in and grabs somebody, it's all for a good cause. So with that, Dorothy, did you want to make a few remarks? So I think many of us in this room know Dorothy Leonie Glasser, and none of this is possible without her. I am grateful to have known her for my 18 and a half years. She's one of the first people I met. And I think we all know she's a fierce lady. We're grateful to be partners with them. Dorothy?
Thank you. You're all too kind. Yes, I am Dorothy Leonie Glasser. I am the Executive Director of the Advocates for Responsible Care. I am the lead on the Georgia RX and Reach Coalition, and I am the chair of this wonderful Georgia Bio Patient Advocacy Alliance. We are here because our priority is giving voice to patients. It has always been to give voice to patients, lift up their voices, and now to bridge the community of the life sciences with the patient advocacy community. We know that together we're all working for the same cause, and that we would have a greater influence on our policymakers and on our communities if we come together and work more together. Oh, I have to have one more acknowledgement. Our Representative Kim Schofield, who is an advocacy warrior, just came in as well. We're forging a new model of collaboration and an enthusiastic friendship, and we'd like all of you to be a part of this. We're committed to educating policymakers and citizens about patients' daily struggles and challenges while we are still supporting innovation and research and development. We believe very strongly that legislation needs to be done to detangle this unfair, unjust health system in Georgia and across the country. We have a system right now that punishes patients for being ill and yet allows middlemen to make billions of dollars in profits. This is hurting the system. It's hurting patients. It's hurting the life sciences. We can do better than this. A system that cheats independent pharmacists and rewards third-party middlemen. Our goal is to help patients, but it's also to preserve innovation. What good is developing a cutting-edge therapy if the patients don't have affordable access to it? This is our goal. As you'll hear today, we have many roads to take. They're going to be long and bumpy. We must not accept any policy that insists to lower the cost of drugs means sacrificing innovation. Many of us with chronic illness live today because of these cutting-edge therapies. The numerous treatments and protocols that I have been through with lupus and my cancer have allowed me to be alive and be here today. I am still on that illness journey. So my heart goes out to all the patients because we never stop. And we want the life sciences to know about the patients that they're creating these innovative drugs for. This is who we are. This is what our daily life is about. And you help us and let us help you so that you can continue to thrive. You can continue to make these incredible discoveries that 40 years ago, 50 years ago, when I first had lupus with a heart attack and stroke and coma and seizures, were not at all possible. We have a dynamic and motivating agenda, hearing from health system policy advisors, patient advocates, and legislators. We welcome you to engage and ask questions of our experts. Please enjoy the program, and please take out your phones and post that you are here at the Georgia Bio Patient Engagement Summit. Thank you.
Still don't know why you never became a politician, Dorothy. You got your stump speech down. That's fair enough. Fair enough. Well, thank you, Dorothy. Always moving and very impactful remarks. Will be a call to action at the end of the program today from Dorothy later, and including one from ourselves. We really want to engage our patient engagement, our patient coalition throughout the year, not just at this event. So do stay tuned. And throughout the day, if you have any questions about Georgia Bio and you can't find me, Mel Carter right here can assist you, and Megan Heafy in the back corner as well. And Mel does manage our patient engagement outreach work and all of our policy work. So I'm very excited about our first keynote. Well, actually, our keynote. What am I talking about? Dr. Rob Provovian. And I'm not going to read his bio. For those in the room, there should have been pieces of paper with a QR code that you can download the whole program for today and their bios and everything. He has a number of different titles with them, and I have it up just so I can say that. Founder of Conquest Advisors, Chief Science Policy Officer for the Global Healthy Living Foundation, which, by the way, I already had and listened to that podcast because it's like this nice short podcast to get my healthy updates for the week. So I'm giving you a plug there. And Senior Fellow health policy at the Progressive Policy Institute. He is the country's foremost expert on every significant facet of biopharmaceuticals and healthcare industry, and he is recognized authority on health economics, policy, government relations, medical affairs, and strategic planning. He's going to cover a wide array of things today, so write your questions down. And I will say, for those that did submit questions, we do have those, but feel free to ask them when we get to that point in the program. So Dr. Provovian, please join up. Thanks so much.
We allowed this unhindered integration of insurers and PBMs, and then pharmacies being purchased by insurers and PBMs. And what has become, we have created oligopolies. There are primarily three major insurer/PBMs that control about 80% of the market today. And this is the reason that FTC got involved, is because it's almost anti-competitive, some of the activities that they do. So one of the things that I want to also point to is not just pharmacies that these PBMs and insurers are getting involved in. Did you guys know that 10% of US registered physicians are employed by United Healthcare? They're actual employees of United Healthcare. 90,000 physicians they employ. But they're not just employing them because, oh, they want to get into this Kaiser type model. They're employing them because they want to leverage their offices to be able to make money off of a 340B program, for example. And we will go through that. And that's the problem. You know, they will talk a good game about how they want to do this. So next slide. All right. So what do PBMs do? PBMs do many things. So they initially started, when I started in this industry in the 1990s, PBMs were really just intended to process prescriptions. You walked into a pharmacy, they would process the prescription, they would tell you what your out-of-pocket cost was, the patient would pay for it, and they would just get a few cents for every processed prescription. That's all they did. They were truly a middleman. Now what they are done is not only they're processing prescriptions, but they're setting formularies. They're setting up how you can access those medicines. They're setting up the out-of-pocket cost for the patients. They own pharmacies. They have now insurers that they've purchased. And they've also created these offshore companies called GPOs. And by the way, they shouldn't be using that terminology because group purchasing organization have existed for a long time. They're not really GPOs. What they're just basically accumulator models of rebates. And the reason they've put it offshore, and they'll be very honest with you, is because they're concerned about US legislation regulating them. And that's why they've created these companies offshore. So there's no ability to monitor that. So they are doing a lot of things besides just processing prescriptions today. Next slide. All right. And this is important because this is another thing that we always talk about, right? We always talk about rebates, and you hear about rebates, and let's pass through the rebates to the patient and everything else. Rebates are about 15 years ago, what the influence was. Today, profitability of PBMs are not really coming from rebates. They're coming from owning specialty pharmacies and owning these GPOs, which are offshore companies. So when Congress is trying to write legislation or states are trying to write legislation, and all they put in the terminology is let's pass through the rebates or let's capture the rebates, they're missing a whole bunch of stuff, especially regarding fees and all of these specialty pharmacies and the GPOs and everything else. And this is important because the profitability of these companies is shifted towards those models. They probably, when CVS CEO gets up and says, we pass on 99% of the rebates collected back to the employers or to the government, he or she is probably telling the truth. But remember, he's only talking, or she is talking about rebates only. They're not talking about all the stuff, the other stuff that they're capturing from the manufacturers that never ends up with either the employer or worse with the federal government, which is unfathomable to me. Like, how could the largest payer or which payers are really either patients or government or employers, okay? They're not insurers and they're not PBMs. How could the largest payer of pharmaceuticals in this country not be able to decipher how much money is being captured by the PBMs? So this is important because when you're thinking about legislation or you're thinking about policy, and if you just use the word rebate in your terminology of what is being captured by the PBMs, you're going to miss about 80% of the other things that they're charging. And that's important. That's why you need to almost have a catch-all. And that's why these transparency laws are so important, to be able to pass transparency to see where every dollar is being captured and what is it being captured for. Next slide, please. All right. So when we're talking about brand name drugs, and this has been a trend for a long time, especially in the last 7 or 8 years, the suppression of the prices of brand name drugs is almost to a negative level. Yeah, pharma can raise the prices and you see the headlines of 7-8%. But what happens with all the concessions and everything else and the rebates and the fees and everything else for every brand name drug? Now they're in the negative level. So what's capturing the growth? Why are we having more spending in the United States for drug? Is really utilization, which is a good thing because the more drugs patients use, the better off they are. So utilization is what's driving spending, because what people always mix up is pricing and spending, and they're two different things. Spending is a function of utilization times price. And what we know from a brand name perspective is that the prices are actually in the negative level. That means that they're not growing. And by the way, this is almost, if you look at the top 10 pharma companies today, they're raising prices, but they're taking less money for every time they raise the price. And what we're seeing is that there's more utilization because we're getting to be an older, United States is getting older. We're living longer because of these pharmaceuticals, and we're using more medicines. Next slide. So what are the dollar amount we're talking about? All of the fees, concessions collected by PBMs and insurers is about $334 billion annually. How much are we spending on drugs, you guys think? It's about 600 billion. So half of it goes into this bucket, all right? That nobody has an idea, a good idea anyways. This is all estimates. And that's why Congress's first job is transparency. We need to figure out where every dollar is going before we do any kind of other policies. Next slide. And this is a perfect case study, right? You guys have heard about the insulin. insulin was the best example of how system is so corrupt. You know, about 5 or 6 before the pandemic, you used to go to state houses. I was in Tennessee. I was here actually in Georgia, and a lot of people were talking about running insulin bills, you know, specifically trying to curtail the cost for the patient. The problem with insulin is that the price has been going up year over year, without a doubt. Retail prices have been going up, but the net price that either Lilly or Novo Nordisk or Sanofi were taking actually has been flat or going down. And if you include inflation during that time, they're actually making less money. That's why it's so brilliant between the three companies. Especially, I give a lot of credit to Lilly because they were the first ones to step up and really cut the price down. Because you know what the price cutting did? It just reduced the profitability for the PBMs. And keep that in mind because we will get back to it when we talk about in the Inflation Reduction Act, because that's coming. That's the next step that's going to create some chaos in the marketplace. But this is exactly it. Look, the net price actually has been, it was 62, 60, 47, 40, 40. Then it dropped to 26, obviously, because Lilly capped it. Look at the retail price, the gross price that they were 275, 275, 275, 275, and it went down to 66. So the margin is the profit that the PBMs were making. So by Lilly dropping their price, the margin is less. And guess who was very angry about this? It was the PBMs. What Lilly, Sanofi, and Novo Nordisk did, it actually created less profitability for the PBMs. It helped patients, but the bigger issue is that it created less profitability. And we'll get back to the Inflation Reduction Act because there are going to be some consequences. Next slide. All right. So you always hear, you know, we give all these rebates and concessions back, but really you do. State of Texas actually passed legislation. This is about right before the pandemic. And they asked every PBM to tell them what happens to this money that they get, you know, from the pharma companies. Do they pass it to the issuer? Do they pass it to the patient? Or do they keep it as profit? So 3 things to remember. Number 1, this is 2022 data, the latest. You see this 0.02%? That's what gets passed back to the patient. Not even 0.02%. 91% goes to the issuer, but keep that word in mind, issuer, because this came up at a House hearing in Texas where I testified because I brought up this issue, and then the insurers came, PBMs came, and the issue of issuer came up. And I'll tell you what the reaction was from the chair, who happens to be a physician. And then they keep about 9.3%. It's up to 13, 20%, you know, as profit. And so when PBMs say, oh, we pass on 99%, no, they don't. It's more closer between 10 and 20% that they keep as profit. But let's keep going to the issuer issue. Go to the next slide. Remember the slide that I showed you? It used to be a time where we had a separation of church and state. Insurers were separated from PBMs. So they basically were the issuer. They were the plan sponsor, right? The issuer is the same company now. So this came up. This came up at that hearing. And when I brought it up and I was challenged by the insurer and the PBM person, the Senate chair, the House chair said, wait a minute, but you guys are the issuers. You're basically passing it from one hand to the other, you know? And that's the problem of the definitions. And that's why second thing that Congress needs to do, not only the transparency, but what do you define as an issuer? The issuer should be the ultimate payer, which happens to be the government, the employer, or the patient. So that's why terminology matters. And this is where PBMs are great at playing games when it comes to legislative efforts. They try to twist the names and words. And as I said, there used to be a time of separation of church and state. We no longer have that. Insurers own PBMs, PBMs own insurers. So when they talk about who's the plan sponsor, you got to really ask questions because plan sponsors happens to be the same organization now. Next slide. All right, this is another study that came out, and you know, there was a lot of brouhaha about, and it was one of the authors it has to be from Sloan Kettering, somebody who was a big critic of pharma, and he did the study and showed, most of these rebates and everything else that you guys are talking about, actually, who captures that? It's pharmacies. Pharmacies are the ones that capture all the benefits of these fees and concessions and rebates. Well, yeah, nobody disagrees. But remember, where does rebating and fees and everything happen? It's in the brand space, right? Who's dispensing brand space to brand name drugs? It's not your retail pharmacy. It's not Save-On not Save-On, but CVS or Walgreens or the independent pharmacies. It's specialty pharmacies. And who owns specialty pharmacies? PBMs. Again, about 80% of the market is captured by CVS, Accredo, and Optum. This is not your mom and pop specialty pharmacy. So these authors were sort of, they found out that, pharmacy captures that. But if the PBM owns the pharmacy, then who's capturing? It's really the pharmacy benefit management company. Next slide. So there are other ways that they're making money. And this is probably the most hideous ways that they make money, because they make money off of patients. They make money off of patient assistance programs. So one of the things that we did at Pioneer, we wrote a paper and we called it Out-of-Pocket Pirates. So, patient assistance program, every pharma company has it. I'm 100% sure if you're a patient on a brand name drug, you're on some type of a patient assistance program. And you've probably heard the terms accumulators or maximizers, which are basically programs that for every dollar given to you as a patient assistance program, that dollar doesn't apply to your maximum out-of-pocket cost. So you're still liable for it. So not only they capture this amount from pharma company patient assistance programs, but then they double charge the patient. Patient still has to pay for it, And so we wrote this thing. And one of the things that, I advocate for passing legislation in the states, and I don't know if Georgia has passed the legislation. I know many other states have, to prohibit this activity. One of the biggest things that you hear from the PBM lobby is that it's going to impact premiums. That as soon as you pass this, the premiums are going to hike up. So what we did at GHLF, we actually went and looked at premiums and looked at states that passed the legislation versus states that have not passed the legislation. And guess what? There's no difference. Premium increases have nothing to do with passing this legislation. All you see is that they're basically both are flat lines. And what you see with actually premiums in states, when you really look at it closely, they either have been going up or down before passage of this type of legislation. So it has nothing to do with it. So protecting patient doesn't cost any more money. That's another lie that the PBM lobby will tell legislators in the state level who have passed it, and they're doing it in the federal level. It's like premiums are going to explode. Not true. Next slide. All right. Now, this is despicable, because what they're doing now, not only with the brand name drugs, but they're taking advantage of patients on generics. Okay, so this came out before the Ohio thing exploded with spread pricing. Really, there was a study done by University of Southern California, and I'm affiliated with it, the Schaefer Institute, and they looked at a retail drugstore, a chain drugstore. Guess which one it is that I'm talking about? It's not CVS. They looked at the patients walking in to that drugstore and what happens to their out-of-pocket costs if they use their insurance card rather than if they paid for it in cash. And what they found out is that 1 out of 4 patients were overpaying for generics only, by the way. They were overpaying for their generic medicine. That means by using their insurance card, they were actually paying more. And it's happened to me, by the way. And it's happened to me more. The reason being is that I walked in to pick up my Lipitor prescription. It's generic. Up until recently, I wasn't paying anything, but we changed health insurers. And for 3 months supply, I ended up paying $22. If I bought 3 months supply at Costco, it's $17. So I'm overpaying by using my insurance card. I could have paid cash. I would have saved money. And this is why you see Cuban pharmacies and everything else coming up. But this is not just about patients. So 1 out of 4 patients were overpaying. But then Schaefer started looking at other things. And then the spread pricing issue broke in Ohio, which is basically, you guys know what spread pricing is that the PBM charged more money to the state Ohio Medicaid program rather than what they reimbursed to pharmacies, and they kept the spread. And we're not talking about small amount of money. It's $200 million over 1 year. The Medicaid program basically overpaid by that much. So what Schaefer did in their second study, and I was involved in that too, they partnered up with Costco, and this published in JAMA. And they looked at the top 200 generics in this country. And they wanted to figure out, they had the dollar amount that Medicare actually reimbursed for those generics versus what it would cost the patients if they would have just walked into Costco and paid cash. And over 2-year period, Medicare for the 200 generics only overpaid by $4.5 billion. It would have been cheaper for the federal government to buy everybody a Costco prescription, just reimburse them straight out what they paid for in cash, rather than they go and reimburse it through the the generics through their PBMs. And this is the problems with the model. That's why you see Mark Cuban out there and these cost pharmacies and Costco's out there, and why patients are switching. But one of the problems is now what CVS and the other PBMs are doing is saying, if you pay cash, it doesn't apply to your deductible or your maximum out-of-pocket cost, which is that's not supposed to be the way. I'm paying cash because I'm finding a better deal. I shouldn't be overpaying for the privilege of using my insurance card. The whole premise of insurance is that you're going to pay less. They're breaking that premise, and the federal government is overpaying for it. Next slide, please. Okay. So this is something Pioneer Institute, which I'm affiliated with, we've been working on for a long time, the 340B program. So 340B program, it's a federal program for people who institutions that take care of patients who are indigent or uninsured. I was involved in it. I trained in LA County, USC. 99% of people in LA County, USC in 1995, when I did my residency there, walked into without insurance. And this program was a godsend because the hospital was unsustainable. They couldn't do it. And they needed this 340B program to be able to sustain their revenue and be able to provide care for these uninsured patients. But what has happened with this program too is that PBMs have bastardized it. If you look at who's involved from a contract pharmacy standpoint, and contract pharmacies have exploded, by the way, since the passage of ACA, because what ACA did, Affordable Care Act did, is that it removed the cap on the number of contract pharmacies. So I'll give you a couple of studies. One study by which we did at Pioneer. If you look at the top 12 contract pharmacies, that means pharmacies nationally that have the most 340B contracts, the first 2 are Walmart, and the next 10 are PBM-owned pharmacies. So now they're getting involved in a federal program for the poor also. Avalere just came out, and their big deal is that 69% of 340B pharmacies are PBM-owned pharmacies. So this program that is intended for the poor and uninsured, that is supposed to be something that is provided locally by pharmacies that are contract pharmacies for patient care in the local communities that are underserved, it's really being captured by the PBMs again. So this is the latest salvo in their business model that they're getting involved in. So what we're trying to do is, in Pioneer, advocate for 2 things. Number one, transparency of where this is going and why so many contract pharmacies. I'll give you the example of in my where I grew up in LA. So there's UCLA Reagan Medical Center and USC LA County. Reagan UCLA is in Westwood, California. If you guys know LA, you know Westwood, that's right next to Beverly Hills. It's a pretty good neighborhood to live in. Reagan has 140 contract pharmacies. About 45% or 50% of them are out of state. They're not even in the community. Okay, and most of their pharmacies are in affluent neighborhoods. They're not in the neighborhoods that these patients are living. USC County facility has 6 contract pharmacies, and all of them are in East LA or South LA, where the patients are living. And this is what you see repeatedly. The large 340B eligible hospitals that are in affluent neighborhoods, and it's just not UCLA, it's Rush Memorial, same thing versus Cook County, for example. It's NYU Langone versus Bellevue. They're taking advantage of this program, and they're the ones that are enriching themselves, and they're buying these physician practices and these other hospitals to be able to expand their services. But who's profiting from it again is the PBMs, because the lucrative contracts that are going on. There was a contract found by Adam Fine, and if you don't follow Adam, please do, because he's really good, that showed that the contract was a Walgreens contract. The contract was for a dispensing fee of a 340B eligible product to the patient. So typically dispensing fees in pharmacies, Greg, what is dispensing fee amount? Usually $10, Greg, $10. The dispense nationally, right? Average is $10. The dispensing fee for this contract was 6% of the retail price of the medicine, plus about $60 or something like that. We calculated, like, if it's an $8,000 drug, we're talking about $1,100 a month on dispensing fee. So that's why these PBMs are involved in the 340B program. They're not doing it because charity care. They're not doing it because they're in indigent populations and serving them, or in communities that are underserved. They're doing it because there's money in it to be made, a lot of money. And by the way, 340B in the next 2 or 3 years will be the largest federal program, bigger than Medicare, actually, with regards to spend. Next slide. Okay, let's talk about Inflation Reduction Act, because there's some, like, with every complicated legislation, there's some benefits and there's some risks. So the benefits are very clear. I mean, there's a cap for patients for out-of-pocket costs now in Medicare for the first time, which Medicare Part D never had a cap, right? It was the only program. Almost all insurers have a cap, maximum out-of-pocket. Medicare Part D never had a cap, so it instituted a cap. Secondly, it normalized out-of-pocket patient for the out-of-pocket cost for patients. So instead of everybody paying in January for their out-of-pocket costs to reach their maximum level, they sort of normalized it. The third thing they did is eliminate, if you're a patient, Medicare Part D, for some bizarre reason, and for seniors, they still had an out-of-pocket cost for vaccines. They removed that, which made no sense, right? This is for elderly patients who are probably going to benefit from vaccines the most, and we were charging money, which made no sense. So I already took that away. They did transfer risk to PBMs from the federal government. And then they capped the insulin prices, which already had been capped by the private sector anyways, but they codified it into law, which is a good thing. Those are the good things. Now, what are the risks? And this is why I wrote about it in LinkedIn, and it's gotten a lot of attention. The risks are, number one, everybody talks about the impact on research and development, and that's undeniable. I mean, you can go look at CBO. CBO scored it. It's somewhere between 15 to 20 molecules in the next 5 years, all the way to some private sector consulting firms have done analysis of about 100 molecules. So I don't know what the real number is, but there's going to be a negative impact on research and development. Everybody's familiar with it. Both sides agree, whether it's the left, right, the government, even the federal government knows it's going to happen. I'm not going to talk about that. What my worry is the erosion of the benefit on Part D, and that's coming. And I'll show you some evidence that we found at the Global Healthy Living Foundation. Actually, we have a published study that we've submitted for pre-publication that hopefully will get a peer-reviewed publication to accept it and publish it. But the erosion of the benefit is risky because of two things. Number one, IRA put a cap on increasing premiums, which is fine. I mean, theoretically, you're thinking, okay, that's a great cap. But because of this cap, now they have very little wiggle room. Remember, they have a $2,000 patient cap now. They have taken on risk, and they can't increase their premium anymore. So what do you think PBMs are going to do? They're going to say, oh, okay, we're going to make less money. We're just going to walk away, right? No. So there's 3 things that are going to happen. Number one, they're going to look for other places to make money that they've not tapped into. So one of the areas that they've already discussed is vaccines. PBMs never try to get any kind of rebates or do any kind of contracting on vaccines because there was no reason, right? There's no benefit to the patient. Patients pay zero out of pocket for this. So what are they going to do? Make more money for themselves, in other words, right? So they're going after vaccines and other areas, specialty drugs, gene therapies, things like that. They're going to come after them. The second thing that they're going to do is that they're going to start eroding the benefit. What they will do is put more administrative burden on the current therapies. And this is going to happen no matter what. But the third thing is the most subtle way that they can do and to make more money. And I wrote, sort of like being flippant, but that every Medicare patient now is going to have a $1,999 out-of-pocket cost. Even though, remember, only 20% of Medicare Part D patients actually go over $2,000. So magically, you watch, everybody who's a senior is going to have a $1,995 out-of-pocket cost or $99 out-of-pocket cost because it's going to hit that threshold. So that 80% that was never paying that, they're going to get there. Second thing they're going to do, and I'm going to show it to you. Go to the next slide. This is just surprising. So we did a study looking at the anticoagulant class because there are two anticoagulants that are being evaluated by IRA. And our assumption was that, look, they're going to start switching patients from different tiers. They're going to put patients from tier 3 to tier 6. So they're going to have more out-of-pocket costs because of this. But then I quickly realized when I started getting this data from, and this is primarily came from IQVIA, we started looking at the data. What bothered me is that the level of differences within the tiers. So this is tier 2 for Eliquis, okay? And this is tier 2 for Xarelto. Look at the distribution between $0 all the way to $200+ out of pocket. We have 24% here, 30%, 6%, 27%, 10%. And this is for Express Scripts, and this is for CVS, because I got both data, and we have Optum too. And they all look the same. So our assumption is, and this is what my guess is, they're not going to even have to move patients from tiers. What they're going to do is shift the 0 to higher levels out of pocket for patients. So the federal government's going to look at the formulary and say, look, there is no more administrative burden. There is no prior authorization or step therapy. In fact, ESI and CVS have kept everybody that they had previously on the same tiers. But because federal government doesn't have this level of data, or they don't require this level of data, they can easily shift this 24% to this $200+ level, or to even $100 to $200 level. The data is so crude. And this is, by the way, the data that gets reported back to pharma companies too. Because it gets reported back to IQVIA, and then IQVIA gives it to pharma companies. And I guarantee you, the federal government doesn't even have this level of data. That they're going to look at these formularies and say nothing is changing, but in reality is that patients are going to pay out of pocket more. And this is why in the paper, we write that the CMS, who is responsible for monitoring this, not only should be looking at formularies as they're constructed today versus, post IRA, but they have to look at specifically required data such as this level of data, and even more specific data. Because think about it, there's a lot of wiggle room between 100 and 200 too, right? So they need to require better data, more accurate data, more specific data to see what's happening with changes in formulary and to out-of-pocket costs for patients. Because fully knowing what PBMs can do, and because they have the data and nobody else does, including federal government, including pharma, including IQVIA and everybody else, that they're going to start playing around even within tiers. And that's our big fear, is that unless we really look at these formularies closely at a micro level and start analyzing the data, that we're going to miss out a lot of stuff that's going to happen to patients post-IRA. So with that said, thank you so much. I will take any questions that you have. Happy to address anything I talked about. Melissa? Number one, you need to become better consumers, especially with generics today. Look, I'm sort of complacent too. My difference was $5 between what I paid for my copay versus what I could have gotten in Costco. But sometimes the difference are significantly more. Maybe $5, maybe it's not a lot for me to make that change. But we need to become better consumers. And by the way, this is something I said to every legislator that I speak with. We're bad consumers of healthcare. Not only as patients, but as government, by employers, everybody. And I tell this to employers too. We're not doing the due diligence for something that's costing so much money. So number one, better consumer. Number two, better advocates. You know, you need to be like Dorothy and other patients set that get out there and talk about their experience of what they're doing, and not be bamboozled by things like maximizers. So maximizer is a good example of how PBM bamboozle patients. So with accumulators and maximizers, the difference is the accumulators that you get the money from the patient assistance program. None of it applies to your out-of-pocket maximum, but you don't have any responsibility after whatever the thing with the accumulators, that you keep being in this deductible phase, right? And you have to keep going back to the pharma company to keep filling up the patient assistance program. What they did with maximizers say, oh, we will still not apply to your deductible, but now what we're going to do is that we're just going to take whatever the maximum is on the out-of-pocket, the patient assistance program, and just apply to that. So you won't have any responsibility. Well, patients are, oh, that's great. You know, I don't have any responsibility anymore. I'm scot-free for that drug. The problem is, and this is the paper that we wrote in Pioneer, we did some modeling. These patients also you have physician costs. You have other healthcare expenditures, other pharma costs. So when nothing is being applied to your maximum out-of-pocket costs, you're going to on the hook for those things with or without the maximizer. So again, be better consumers, be better advocates, and don't be bamboozled by the PBMs. Ask questions and ask questions. And the third thing is demand patient choice. One of the things I'm going to do a podcast, actually, we're recording it tomorrow. We have two people in GHLF who have been steered to PBM pharmacies. And we're going to bring them up and interview them. And one of them fought back, demanded that, no, I want to get my drug from the local pharmacy. And the reason being, it was very practical. It was not even for out-of-pocket costs for him. It's because when CVS was doing it, they would bring the FedEx and throw it in the front lawn. And it was a biologic that he's taking, versus the local pharmacy would call him, make arrangements to deliver the drug when he was home, and sign for it. Okay, so practical issues. So things like that. So I would say those are the three things: better consumers, better advocates, and demand. Okay. Yes, sir.
Yeah. So back to your earlier question. So Georgia was either the fifth or sixth state that passed the copay accumulator. I think it was House Bill 946.
The ban, you mean?
The ban copay, yeah. So I think it was House Bill 946. One of the fifth or sixth states, I believe. My question is related to IRA and these different tiers here. Are you saying that the range will go up because of the IRA MFP?
Yeah.
Okay.
Because what they will do is, because CMS is supposed to review these formulas,
Correct.
right? You really think CMS is going to look at what percentage of patients shifted from $0 to $200+ in tier 2? No, I can tell you that. No, they're not going to even want to see that data. And that's what I think. What we're predicting is that in the surface, the formulas are going to look the same. They're not going to be changes in tiers for patients, but within tiers, they have so much wiggle room that they can screw with the patient's out-of-pocket costs and make more money.
Thank you.
Are good? Or
funds are being robbed
Mhm.
by the PBMs. Can we not eliminate both of these and have any money that should be going to the patient directly to the patient
Okay.
and bypass the PBMs?
Okay. The largest state in the United States is California. The largest insurer in the state of California is Kaiser. Kaiser does not use a PBM, nor do they do rebate contracting or have any kind. They just take flat net price from pharma. If Kaiser can do it, I think other states, other insurers can do it. Okay, so this is all an excuse. The largest state, the larger insurer in the largest state in the union does it. And it all goes directly to the patient, whether it's direct to the patient or to the premium or whatever it is. I don't, but if they can do it, everybody else can do it. Any other questions? Eric.
Robert, a couple of years ago, you helped me to better understand PBMs. I had no idea they had so much buying power that I think most people don't realize they buy so many pills a year. It just gives them the ability to tell a pharmaceutical company, this is what we're going to give you for your drug. But I had a real aha moment when you gave me a comparison with a Pfizer drug that I think that year the price was raised 8% and the PBM came and negotiated down 9%.
Yeah.
It really helped me to better understand that.
Yeah. It's a negative.
Is that why pharma companies increase each year knowing they have to hedge or bet?
Yeah.
Because the PBMs are coming.
Yeah. I mean, look, it's again, it's not for every product, right? Let's be honest. Pharma companies also make money and they raise the prices and they make money. But in average, if you look at pharma and brand name drugs, it's negative. That means for every dollar they raise, they're probably giving $2 back on average. Some drugs are going to make a lot of money, but because of competitive marketplace, I mean, some of these rebates and the concessions are out of control in some of the drug classes. I can tell you in the autoimmune drug class, like Humira or Enbrel and things, those concessions run up to 70% sometimes of the price of the medicine. Where does that 70% go? That's the question I want to ask. You know, who's benefiting from this? It's not the patient. It's not the, I can tell you, it's not even the employer or the federal government. It's somebody else. And that's the problem. You're right. Well, by the way, one of the things that also PBMs do, which is the FTC did a good job of documenting in their initial report, is undermine the independent pharmacies by doing this dual reimbursement thing. And fortunately, there's Senate legislation now that some congressional member I work with sent it to me and asked my opinion, that's going to prohibit PBMs owning pharmacies, which is, I think, the best thing that can happen. That will start right-sizing the market. If they cannot own the pharmacy, specialty pharmacies or independent pharmacy, retail pharmacies, that'll go a long way of fixing some of the problems. Any other question? Yes, sir.
So, I'm not a pharma person, but what are the redeeming qualities of PBMs?
Okay.
They must serve some purpose
They did.
because they're certainly very valuable.
Number one, they cannot go away because the processing of prescriptions needs to stay intact, because that was the problem, right? When I was starting in pharmacy, when I was a student, you used to walk into a pharmacy, nobody knew exactly what their out-of-pocket costs. You had to pay out up front, then you may get reimbursed back from the insurer. What PBMs did is that really fixed that issue, which is processing of the prescriptions, what your responsibility was as a patient. The pharmacist would get reimbursed right away. So the processing of prescriptions have to stay intact, and PBMs are needed to do that part. But the way I say that is that when you go to a Wells Fargo, well, it's like putting your money in a savings account. That's how they think of their processing prescriptions, is like that 1% growth per year. Versus everything else, the hedge fund stuff that Wells Fargo does and makes a lot of money on, the risky stuff is where they do the other stuff. That other stuff, and again, I don't have a problem with them doing that other stuff, but let's have some transparency of where the dollars are going, you know? So if the federal government is not going to regulate it or the states don't want to regulate it, but at least find out. I mean, that my discussions when I talk to the either congressional members or I talk to the staff in agencies, I'm like, why aren't you asking? You're the federal government. You can demand this information. And they're like, oh, well, you know, I don't know. It's just some legislation or they're lazy or whatever. And that's the problem I have. It's that let's at least get to a point that we know where the hell is this money going. And then we can start fixing the model. I have a good slide on that. I didn't have it in my deck. But number one, you need transparency because this is the problem. And I know people tell me transparency is not going to do anything. It's not going to fix the model. I'm like, yes, it is. Because every time you pass legislation without knowing exactly what you're passing and the impact, then you're going to do the wrong thing. So number one is transparency, is accountability. Let's have an accounting of every dollar spent, right? Truly every dollar and the net dollar spent. That's number one. Number two is the micro level changes that need to happen, whether it's the 340B program that needs to be regulated, you know, whether it is specialty pharmacy steering of patients, the accumulators and maximizers, those are the things. And at the end of the day, one other thing I would say, and pharma needs to do this. And when I was at Pfizer, I advocated for this, and I still advocate it today. Pharma needs to do a better job of explaining their pricing model. You know, there's a whole slew of people within pharma where I used to work that know exactly to the penny why they price the medicine. But guess what? They're muzzled. They're not allowed to talk because there's also a cadre of people within pharma who are former PBM employees who are working with pharma who think that the model should not be transparent and nobody can talk about it because that's the only way that we can do business. So pharma needs to change too on that one.
Good morning. My name is Shannon Ragland Lake. I turned 50 years old in October this year. And I don't know what I want to be when I grow up. Sure. I'm a gardener. I paint in watercolor. I'm a former web designer, a creative project manager and producer. I have a BS in neuroscience from Vanderbilt University. First and foremost, though, I'm a patient. I've seen many doctors starting at just 10 years old. I've received several diagnoses from childhood through adulthood, mostly in the autoimmune category and all incurable. I was surgically diagnosed with juvenile rheumatoid arthritis, or JRA, when I was 13, affecting both my knees. I left for college at 17 to study pre-med, and my disease spread to most of my joints. When I was 20, my pain and inflammation was severe enough and my health had deteriorated enough such that I used forearm crutches to walk. My parents took me to Mayo Clinic in Jacksonville for a very different college spring break, a week that changed my life. I saw multiple specialists, including a wonderful rheumatologist who was more aggressive, recognizing that my disease was quite active and that it was time for adult strength medications. He also recommended daily physical therapy after he told me and my parents that my trajectory was not what he would want, that at the rate I was going, I would be using a wheelchair within a year. I also saw a psychiatrist who for the first time recognized my long-time organic depression and treated it. My depression was palpable. I was looking around at my peers working hard and playing hard and realizing I may never be pain-free. I worked hard in physical therapy and recovered enough that after graduation, I had an opportunity to move to New York City to act. I was successful, but unfortunately my disease flared so badly from the stress of the unpredictable and physically strenuous daily life of getting around in Manhattan. So then I moved to Charleston, South Carolina for a much slower life. During this time, I started the first biologic approved for JRA, and it was miraculous. I began a 2-year remission. The first time I took it, my perennially swollen knees were skinny with no fluid for the first time since my surgery when I was 13. At first, because these treatments were so new, there were no copay assistance programs. In fact, I had to pay over $1,000 out of pocket every month and be reimbursed weeks later for the percentage paid by insurance. I was a realtor and a model in Charleston, a situation which was neither a good fit for me nor sustainable with the cost of insurance and treatments. I moved back to Atlanta at age 23 to take prerequisites with an eye for beginning a PhD program in neuroscience at Emory. Because of the cost of my treatment, I had to move back in with my parents and commute from Dunwoody. I wound up in the ER for heart, lung, and neuroimmune symptoms that never made any sense until my diagnosis just 2 years ago in 2022 of hypermobile type Ehlers-Danlos syndrome, or HEDS. In the end, my body couldn't handle the long commute, and I couldn't afford a place of my own closer to campus and insurance and treatments and school. I pivoted to taking web design classes at the Art Institute of Atlanta, close to my parents' home, and worked with them in our e-commerce startup and artisanal coffee business. For the next 25 years, I've struggled with my health, going through 14 biologics by 2023. Sadly, only 2 have worked for me. The patient assistance programs became available, but at first one had to jump through hoops and meet financial requirements to be eligible. Thankfully, that process evolved and is seamless these days. I got to live with my parents until I moved in with a young man in 2003 who later became my husband. At this point, my individual insurance policy that covered my meds went up every year, ultimately being terminated in the mid-teens after skyrocketing to over $1,600 a month. In 2009, I discovered patient advocacy on social media. Facebook support groups and blogging connected patients for the first time. Meeting fellow patients was life-changing. In 2010, I met Kelly Young, now Kelly O'Neill, known for her blog RA Warrior. She started a grassroots nonprofit to focus on patient education and the rheumatoid patient voice, building bridges with rheumatologists, researchers, and the pharmaceutical industry. With the help of an injectable biologic, the second to miraculously help my symptoms, I rose from a sporadic contract project manager to a full-time position as a senior producer at a digital marketing agency. I worked primarily with AT&T, Home Depot, Assurant, Georgia Pacific. When I lost my health insurance in 2017, due to Blue Cross Blue Shield pulling out of the individual market in the state of Georgia after 23 years with them, I was forced to switch carriers. Because of formulary exclusion, I lost access to my biologic. I later had to quit my dream job. I found myself sick, angry, and with time on my hands, so I found good trouble, rallying at the Georgia State Capitol for healthcare reform and access to care. That's where I met you. My friend support team. In 2019, I became a volunteer for the Arthritis Foundation and met a woman who had changed my life. The Georgia Advocacy Chair, she asked me to speak at Step Therapy Reform Day at the Capitol. After all the years of work by the RX and Reach Georgia Coalition, we passed the Step Therapy Reform Bill just a few weeks later. After 38 years, Dorothy stepped down from the board and tapped me as her successor in Georgia. During the stress of the pandemic, I developed psoriasis and changed rheumatologists. Because it shifted my diagnosis to juvenile onset psoriatic arthritis, it opened the door to more therapies. I've tried 4 more biologics, but still have not found a treatment that works. For now, I'm stable on low-dose steroids, which is not ideal long-term. There are an estimated 300,000 children and teens in the United States with juvenile arthritis. 6% of those are estimated to be juvenile onset psoriatic arthritis. I was one of those children. I grew up, but I never got better. Contrary to what my pediatric rheumatology told us when I was diagnosed in 1988 with only 2 joints involved, I did not grow out of it. In 2020, I had a hip replacement. The severe damage was not only from inflammatory arthritis, but also from osteoarthritis, from hip dysplasia related to another diagnosis. The complications of that surgery led me to be diagnosed with Ehlers-Danlos syndrome, hypermobile type. Ehlers-Danlos is a group of 13 genetic disorders that affect connective tissues, which support the skin, bones, blood vessels, and other organs and tissues of the body. Hypermobile type EDS or HEDS is characterized by increased range of motion called hypermobility that affects joints, involving frequent dislocations. Faulty connective tissues throughout the body cause chronic muscle and joint pain. People with this variant generally have soft, velvety, stretchy skin that is fragile and bruises and breaks easily. Unlike other types of EDS, mine has no available genetic test, so it is woefully underdiagnosed. I had to go to Tulane to get a diagnosis. My childhood best friend, who also was a former dancer, also has it and was diagnosed in Charleston at MUSC and also had a hip replacement. What are the odds? We hypermobile EDS patients commonly have trouble healing with abnormal scarring, as well as cardiac issues like mitral valve prolapse and increased risk of aortic dissection. It is a highly variable and heterogeneous condition. Additional comorbidities comprise the Pentad super syndrome, which is me. It includes HEDS, autoimmunity, mast cell activation syndrome, dysautonomia, and GI issues such as gastroparesis. Prevalence, unlike the other types of EDS, has evolved from being considered rare to 1 in 5,000 in 2017 to 1 in 500 according to newer studies. It may even be higher because so few doctors understand it. MUSC has recently discovered a gene variant common in HEDS. We need a genetic test and treatments desperately. What the biotech industry has miraculously done for juvenile arthritis, we need for HEDS. Evidence of the amazing innovations in treating juvenile arthritis was made clear last autumn when I joined other Arthritis Foundation Georgia board members at the Juvenile Arthritis Family Summit here in Atlanta. Out of several hundred children and teens in attendance with their families, I only saw one wheelchair and one set of crutches. This is a huge departure from what juvenile arthritis looked like in the 70s, 80s, and 90s. It is staggering that this change has happened in my lifetime, and biologics are the reason. We must work to make them accessible and not let insurers and PBMs play games to maximize profits that result in limited or no access. So what can I tell you that I've learned from my patient journey? The learning curve when you first get a diagnosis is steep. Getting a diagnosis is a shock and can be a little paralyzing at first. But this paralysis is dramatically lessened by access to information. Learning about other people's experiences via online support groups and social media makes it much easier to receive and deal with a new diagnosis. It helps to find a community of people with different backgrounds, education, and professional experience. Getting to meet those people in person is even better. It may take many physicians, tests, and therapies to find your correct diagnosis. This is hard even for caregivers to accept. My parents definitely. A cooperative relationship with healthcare teams is imperative to better health outcomes and feelings of belonging and hope. Validation, education, and empowerment flip the notion that patients are without control over their bodies and circumstances. I learned that knowledge allows us to accept the diagnosis, collaborate on a treatment plan, and execute it. What inspires me to be an advocate and stay involved with both the Arthritis Foundation and RX and Reach Georgia Coalition is that through my patient advocacy, I've met many patients around the country who struggle to access their medications and treatments. It simply should not be this difficult to get healthcare. My ask today is that you join our coalition. Learn to advocate for legislation that helps patients improve their lives by opening the door to removing barriers to care that destroy patients' ability to afford and access their medications and treatments. Thank you.
We're going to first hear a video message from Buddy Carter, who's been a huge advocate for patients and a number of other issues. He was unable to make it today, but he did want to send a message, so we're going to start with that.
Hello, everybody. I'm Congressman Buddy Carter, and I have the honor and privilege of representing the 1st Congressional District of Georgia. The 1st District is my home. It's where I've lived my entire life and where I intend to live the rest of my life. I say this all the time, but out of 435 congressional districts, I'm lucky enough to represent the very best one. I might be a little biased, but I'm also serious. For a bit of background about myself, I started my own pharmacies from the ground up and grew it into a successful operation of 3 pharmacies as well as an institutional pharmacy servicing nursing homes before making my way to Congress. I still retain my pharmacy license to this day. As a pharmacist for over 4 decades, starting when I was 10, I've seen firsthand the role pharmacy benefit managers play in driving up costs for medications and delaying necessary treatments for patients. I was the one who had to watch the senior citizen try to decide whether they were going to buy their insulin or buy groceries. I was the one who watched a mother cry because she couldn't afford the medication for her child. I was the one who watched all this happen, and I knew behind the curtain that the pharmacy benefit managers are the root cause of high prescription drug costs and inaccessible health care. PBMs are driving up the cost of health care and bring no value whatsoever to the patient. Today, 3 PBMs control nearly 80% of the prescription drug market. They own or are owned by insurers and have vertically consolidated them businesses to own everything and everyone between themselves and the patients, including doctors, pharmacies, group purchasing organizations, and more. Thankfully, 2 years ago, the Federal Trade Commission, the FTC, launched an inquiry into the 6 largest PBMs' unfair and deceptive practices on patients and pharmacies. Now, we have been told that the FTC investigation can take anywhere from 2 to 5 years to complete. However, we've already seen positive results from the study. About a year ago, the FTC voted to withdraw all previous comments and advocacy statements in support of PBMs because they no longer apply. And finally, after 2 years of waiting, the FTC released an interim report that underscores the impact PBMs have on the accessibility and affordability of prescription drugs. The interim report found what we have been saying all along, that PBMs profit at the expense of patients and independent pharmacies. I've also introduced several pieces of legislation to combat these many abuses. The Lower Cost, More Transparency Act, which passed the House in December, contains 2 of my PBM reform bills, the Drug Price Transparency and Medicaid Act and the PBM Accountability Act. The Drug Price Transparency and Medicaid Act bans the use of spread pricing by PBMs and Medicaid and allows pharmacies to be reimbursed at an appropriate rate for dispensing medications to Medicaid patients. The Pharmacy Benefit Manager Accountability Act would raise reporting requirements for PBMs to increase transparency in the drug supply chain. Another such bill is the Help Copays Act, which would protect patients from harmful insurance and pharmacy benefit managers' practices that raise out-of-pocket drug costs. The bipartisan Help Copays Act would prohibit the use of copay accumulator schemes that health plans and PBMs use to pocket a patient's copay assistance by excluding the cost-sharing assistance from counting towards a patient's deductible or out-of-pocket maximum. Only health plans and PBMs could take a program designed to reduce patients' out-of-pocket prescription drug costs and turn it into a money-making machine. There's still a lot of work left to be done in this space, but we're taking big steps in the right direction. This brings me to my final point. You are all uniquely positioned to help educate your members of Congress on these issues. Advocacy works, and you can make a difference. Once again, I wish I could be with you all today, but I'm happy to be able to share remarks with you. Thank you all. God bless the 1st District of Georgia, and God bless America.
So we're going to have one more person, and Beth, I'm pointing at you, you're next. We're going to, 2 years ago, was it 2 sessions ago, Beth, or 3 sessions the RDAC was approved now? 3, yeah. So 3 years ago, the coalition, many of us in industry and in the public sector, worked very hard to establish a Rare Disease Advisory Council. I am happy and proud to sit on that on behalf of the industry, but our fearless chair for the RDAC, it took us a couple of years to get all the appointments, but we finally started meeting this year, and I asked our chair to join us today to make a few remarks on why this is important, particularly for patients with rare disease.
It's an honor to be here with you today. My name is Beth Wynn, and I'm a registered nurse. I'm actually living with more than one rare disease, rarely recognized in medicine. My background, in 2012, when I was working in a busy ER here, Piedmont Hospital, in fact, is when I started having symptoms, many symptoms that were unexplained. And from the onset of that to answers took more than 5 years. so I can identify. That was heartbreaking because it ended in heart failure. And quite frankly, if a registered nurse with critical care training and 15 years experience can fall through the cracks, what does that say? That really started me down the path of trying to advocate and become and learn everything I could about why that's happening. What can we do to help? That inspired the change. So now I'm a fierce patient advocate. I'm a leader. I wear several hats alongside some incredible leaders that I'm honored to serve beside. They're in this room today. And essentially, I'm passionate about giving back to the rare community. There's 25 to 30 million Americans living with a rare disease and 350 million worldwide. So chances are you know somebody with a rare disease. And that led to many hats. I serve as a founder of Rare Strides. I also serve as a founder of Rare Wish and chair of the Rare Disease Advisory Council. So what is an advisory council? The Rare Disease Advisory Council, it acts as an advisory body. It gives our rare community a stronger voice within the government here in Georgia. And in 2015, the first RDAC was created in North Carolina by patients, caregivers, families, and providers. Again, advocacy is strong. We can accomplish a lot. Since then, 26 additional states have established advisory councils. In Georgia, our grassroots efforts started out in the square in the rain in 2015. We started out there advocating for Rare Disease Day to raise awareness around rare diseases and make lawmakers aware of some of the problems and disparities we faced. Not only that, but meeting the faces of others battling rare diseases. I think the first time I went out there and 20 people showed up, I cried. I was like, oh my gosh, someone else, this is amazing. Thank God I'm not alone, right? So we kept raising our voices and continued to share the journeys. Did we have battles that we struggled with? Absolutely. There were several years that we were very close to passing legislation and getting something done, and it just got shot down last minute. But instead of giving up, we all got up and we continued to fight. So we kept raising our voices. We continued to share the journeys. Sharing the journeys is incredibly important, because it gets the attention of those who can identify, who understand the struggle. That got the attention of key decision makers. So thanks to the collective voices of incredible leaders, patients, organizations, and sponsorship, Nathan over here, Rep. Chiokas, Cooper, I can keep naming, but legislation HB 918 passed. That happened on May 2, 2022, and officially established our council. With the support of patient organizations, patients, and stakeholders in the rare community, our RDAC here will enable us to identify and address barriers that prevent those of us with rare diseases from obtaining proper treatment and care for our conditions. We have to start somewhere. We need to know where the disparities are so we can address them. RDACs address the needs of rare patients and families by giving stakeholders an opportunity to make those recommendations to state leaders to then make decisions on critical issues. And that includes continuing to address the need for ongoing innovation and better access to treatments and care. So thank you so much for letting me say a few words, and that's all I have.
And the RDAC is working to create a website and some accessibility just for everyone that may want to listen into our meetings as they get more frequent. Let me see. And you're here. Who else is on the RDAC with me that's here? It's just the three of us right now, right? Okay, so that's Nathan, also one of our fearless patient advocates. So back there. Yes, he sits in the RDAC as well. Let's make sure we acknowledge him. So I'm excited for this next conversation. So we're going to welcome up here Dorothy, I'm looking at you. Dorothy is going to moderate a conversation between Dr. Jasmine Clark, Representative Dr. Jasmine Clark of the 108th District of Georgia, and Greg Raybould, the Vice President of Healthcare Policy and General Counsel for the American Pharmacy Cooperative. I think they're going to give two different types of perspective, state here, federal and state from Greg, and it should be a dynamic conversation where we can also bring in some questions from the audience. So I'll hand this over to Dorothy, and come on up, guys.
Thank you again for sticking with us. Representative Dr. Clark, we've known each other a long time.
Oh, yeah.
Dr. Clark started the March for Science in Atlanta
2017.
in 2017, she's reminding me. And ARXC joined her to organize that. So tell us a little bit about what you do when you're not under the dome, because I think that's important to make people understand what your connection is here.
Yeah, absolutely. So the Georgia State Legislature is a part-time legislature, which means that we, many of us also have full-time jobs. I am an assistant teaching professor at Emory University. I teach in the biology department now, but for the last 10 years, I've been a lecturer at the Nell Hodgson Woodruff School of Nursing at Emory University. So I am just now transitioning to the college, to the biology department. But I focus on teaching pre-healthcare professionals. I taught anatomy and physiology, microbiology, pathophysiology. And then the last couple of years, I've also had the opportunity to teach a health and social policy and ethics course to students and nurses to get them to understand the importance of advocacy and advocating for yourself, for your profession, for your patients down at the state capitol and at the federal level as well.
Thank you. Tell us a little bit about what inspired you to run for office in the state of Georgia.
Well, I do think that it's very important when you have a room full of people who are making decisions for millions of people that you have a diversity of perspectives. And one of the perspectives that I felt was really missing in the room was that science perspective. There are not a lot of my colleagues that have PhDs in microbiology. In fact, I might be the only one. And so what that means is the way I approach legislating in Georgia, or the way I approach reading bills, or the way I approach asking questions might be very different than some of my colleagues. And I think that is important. I think having people in the room that approach things in different ways, instead of just having this homogenous set of ways that people do things, is really important. It increases accountability and transparency. And so I decided to run to be a science voice for the state of Georgia, and was elected in 2018 and reelected subsequently in 2020 and 2022, and hopefully this year.
Thank you. Let's talk about that word in Georgia that nobody really likes to talk about, Medicaid. Yeah, we know, those of us who've been around for a long time, that there are thousands of people who are falling through the cracks. They're not able to qualify for assistance to get private insurance, and yet we don't have expanded Medicaid in Georgia. What we have so far, as we know through the research and statistics, is not working. Tell us about your feelings about Medicaid expansion and what we can be doing to make this happen.
So I think it's important to, I'm sure most of the people in this room are aware, but for those who aren't, Georgia is one of the worst in the country when it comes to its uninsured rates, and that includes uninsured children as well. So we are in a position where we have millions of Georgians who do not have access to healthcare, affordable healthcare. And I always believe that a healthy Georgia is a thriving Georgia. Even if I have access to healthcare, if my neighbors and the people in my community don't, that still affects me. And so, when it comes to Medicaid expansion, we are one of only 10 states in the entire nation that has not expanded yet. And that is leaving billions of dollars on the table that could be coming to our state. At the same time that we are turning away these billions of dollars, we are also seeing the closure of hospitals. And I think that a lot of times when people think hospital closures, they think, rural areas that, there's just not enough people there to keep that hospital open. I think we got a reality check recently when a hospital in the middle of downtown Atlanta closed, and we realized this is more than just about not enough people. This is about not enough insured people that are able to pay for their care. And so the Medicaid conversation, I've only been in the legislature for 6 years, and the Medicaid conversation to me has evolved over time. I feel like when I first got there, it was almost like a non-starter to my colleagues on the other side of the aisle. Then the more and more we talked about it, the more and more people seem to be softening their position to some type of Medicaid. And this last legislative session, we just got so close. And although we did not get over the finish line and we did not pass the 138% of the federal poverty level to be eligible for Medicaid in Georgia, we got closer than we've ever gotten before. And I think that has to do with the reality of the situation and more people saying, I feel like we need to do something because whatever we're doing right now is not working. And so I think that this conversation is moving in the right direction, much slower than I would like for it to. But I do think that we will see Medicaid expansion. I know that the governor right now is really trying a whole lot of other policies, trying to figure out all these other things. But unfortunately, what we've seen, the numbers just don't bear out that these policies are working, whereas they were expecting to get tens of thousands to hundreds of thousands or at least 100,000 people on their current Medicaid pathways to Medicaid program. It's been less than 5,000. And this is after a year, whereas our neighbor in North Carolina, when they fully expanded Medicaid recently in December, they've already seen hundreds of thousands of people sign up. So we know what people want. The interest for full Medicaid expansion is there. And I think that we can get there. But it really does take people like the people in this room advocating and saying, this is what we need. And the time was yesterday.
Thank you for that. I know that there is, and later we'll make sure that Representative Schofield also comments on this. We know how much we have been battling this for a long time. Tell us about the climate under the dome. You mentioned that you're seeing more and more progress. What is it going to take in the next session for us to be able to get this over the finish line? And tell me one specific thing that as advocates we can do to make this happen. I can remember when I was in that position that I made too much money, so I was not eligible for any of the incentives that would pay for private insurance. I went years without insurance with a systemic lupus and cancer diagnosis. I had a $600,000 bill that I was in debt for to pay off. It's part of why innovation is so important to me, because had I not been able to be eligible for the protocols that I went into, I would have never been treated and I would have died. So tell us what can we do to say one thing as an advocate that we can do to make the difference and have our other legislators under that dome hear us?
I think that for some people, they are driven by, I just want to do the right thing and make sure that people have access to healthcare, because that is what drives me. I think some people are driven by the fiscal argument. And so I would say when you're reaching out to people, kind of try to gauge, maybe based on how they voted on other things or what they talk about when they do get on the microphone, gauge what they are motivated by and make that argument, because there is both a just moral argument for why we should expand Medicaid in Georgia, but there is a fiscal argument as well. We are leaving money on the table. We are spending money that we should not be spending. And the overall result right now of not expanding Medicaid is it's costing us a lot with very little return on investment.
Thank you. Thank you so much for that. I think it's so important that we raise the voice on this issue because, like you said, we are so much closer, but at the same time, I think for some people under the dome, it's strictly political.
And can I just add to that? We got very, very close. I would say, yes, definitely advocate to myself and to my colleagues, but I would also, send a message to the governor and let him know how you feel about it too, because he is driving this train. And so that's important too. I think he should hear from more people about how they feel about this.
Yeah, our voice as advocates counts. It really does. It makes the difference. Thank you so much. Greg, my dear friend, I get all the good information to hound our legislators with about PBMs from Greg and from the Pioneer Institute. Greg and I have fought many battles under that dome, and we're making some progress, but not enough. Not enough. You have a very strong history of developing this legislation that monitors and regulates PBMs and getting legislation enacted into law. Tell us what we don't know about the PBMs to make a difference here in Georgia and at the federal level.
Yeah, and thank you for having me. I'd like to add a caveat because when you hear the stories in this room and the folks that are here, I think this is the reason why we win. And sometimes I think, particularly from a patient perspective, things seem insurmountable. And when you look at the track record in Georgia and working with you and Bethany and Heather, who is just an awesome patient advocate on the copay accumulator back in probably 2020. Mm-hmm. The truth is we've won more than we've lost in Georgia on the PBM issue. And I think, in large part, it's because of the stories that patients have to tell, right? And, as a patient, an advocate, it can seem really, really overwhelming when you go down to the state capitol and you'll see sometimes upwards of 40 or 50, lobbyists representing insurance companies and representing pharmacy benefits managers, and they're in their fancy suits. And I think it could seem intimidating, and y'all may not believe this, but what I'll say is they're more scared of you than you need to be of them, right? When patients come down, they don't like it, right? And I promise you, when Dorothy walks in the room, everybody's tensing up, right? They don't want to see Dorothy coming. And you have friends, right? You have friends under that gold dome on both sides of the aisle. I would say historically none bigger than Representative Schofield. She's, whether it's a Democrat bill, whether it's a Republican bill, she's always willing to be a top co-sponsor and a top lead on that. And so Georgia passed the first Patient Protection Act in 2017, first steering in 2019, copay accumulator, Heather, 2020, right? So there is this track record.
Step therapy, 2019.
Step therapy, right? And y'all may not know this, right? That was a really big deal. That was a really big bill. And there are PBM and insurance lobbyists every year that are trying to gut that bill, shopping it to various legislators and sort of mischaracterizing what that would do, particularly with regard to biologics. Very, very sneaky with what they try to do with biologics there. So, there have been tremendous strides made. There's massive work to do in terms of passing PBM reform, and I would say even more on enforcing PBM reform. And so there are some great laws on the books in Georgia that largely go ignored every day, and we haven't seen significant enforcement. And one of the things that we're trying to urge is, hey, let's get providers to file complaints and let's get patients to file complaints. Because what the insurance companies and the PBMs know is, hey, if we can ignore this law all year long, and if we get 6 complaints and we pay a $10,000 fine or $1 million fine, that's a good day in the office because they just made money, right? And so half the fight is getting the legislation passed. I hate to say that's the easy half because it's really hard to pass any bill, but by God, enforcement is proven elusive. And so there's significant work to do there too.
Yes, it was great. Dr. Pavovian spoke to us, and one of the key things that I was picking up constantly is let's push more for transparency. So, we look at copay accumulators, we look at maximizer programs, we look at rebates. Maybe we're looking in the wrong direction. Maybe we really need to look at more comprehensive transparency. And tell us a little bit about that, and at the federal level, the accomplishments that Representative Carter alluded to.
Yeah. And so, it's a unique time. If you went to DC 5 years ago, I would say 80% of the offices didn't know what a PBM was. They knew what an insurer was. They didn't really know what a PBM is, right? We're at a point now where almost every office knows what a pharmacy benefits manager is, largely because of patient advocates and pharmacy advocates as well. In my office at home, I've got a VHS cassette that says PBMs 101. VHS cassette, like that's how long pharmacists have been like ringing the alarm saying, oh my God, there's problems here, right? So in a way, I say it's almost like a tale of two cities, right? It's really exciting time. There's over 50 bills at the federal level now dealing with PBMs and drug pricing, which is really, really good. If one of them were written by Dr. Popovian, I'd be really, really happy because he gets what so many don't. And so, there's a lot of bills that play on the fringes of transparency. And it may say something like, hey, the PBM has to report all drug pricing, discounts, and rebates to the prescription drug plan in Part D. Well, as Dr. Popovian alluded, the prescription drug plan in most cases is either owned by the PBM or owns the PBM in some various capacity. So essentially, they've got PBMs. The majority of legislation, they've got PBMs reporting to themselves. Or if they get caught violating a provision of the law, they've got PBMs paying fines to themselves. So really, really circular. So there's been great strides made. There is more work yet to do, right? A lot more work yet to do. Lower costs, more transparency, 5378, which Congressman Carter's been a major part of, has really solid transparency provisions, also has some meaningful Medicaid managed care reform. So that's really, really good. There's a bill by Congressman Auchincloss and Harshbarger, bipartisan bill, HR 9096, that we're working really, really hard on. And listen, big fan of transparency. There are some things, from our perspective that we know are really, really bad, right? And so we've got PBMs steering literally the sickest patients in the country into their pharmacies and marking drugs up make-believe amounts. So they're taking away patient choice. They're delaying patient care. They're interrupting patient care. And so we've got a study that's going to be coming out, or a report that's going to be coming out this week, looking at federal employee health benefit plan. It doesn't get a lot of attention. Usually hear about Medicare Part D, right? That gets a lot of attention. Medicaid managed care and the spread pricing, that gets a lot of attention. Federal employee health benefit plan doesn't get a lot of attention, right? What we see in that plan is massive, massive problems. Patient steering first amongst them. And so we've got examples. I think the most egregious that we found is, and this is a current price, so an MS patient in the federal employee health benefit plan, a particular insurer within that plan, they're forced to go to the PBM pharmacy, and it's a 47,000% markup from national average drug acquisition cost, right? So they're taking away the patient's ability to use the pharmacy of their choice, and then they're marking the drug up 47,000% above a national index of what that drug price is. And so Dr. Popovian, I think nailed it when he said, hey, patients, you can be better consumers, right? There's nothing right. You're not bad. When insurance is costing you money, boy, that's a problem. And when you can get that same drug at a cash price at a Mark Cuban or a Blueberry pharmacy for, way, way less, you've got to look at those options. But we're in a situation right now where the PBMs are steering with impunity in these federal plans. Impunity. And they're marking up and manipulating drug prices with impunity to the benefit of their shareholders at the expense of patients, taxpayers, and then also providers themselves.
I think we also see this in our state insurance plans. And our problem under this dome is that they never let us include state employee plans
Over and
in
over.
our legislation.
Yep, over and over. And we uncovered this year in the Georgia State Health Benefit Plan some significant pricing disparities. So if you went to a retail independent pharmacy, it would cost a patient in State Health Benefit Plan $1.92 for a torvastatin, right? If you went up the road to a chain, it would cost up to $89. And so the patients out of pocket would have been either $1.92 or up to $50 of that 89. So we're seeing significant drug pricing manipulation on your common generics, to your point. But that same plan, again, has massive markups on exactly what those specialty drugs are. And there was legislation introduced to move to an index, transparent index market-based price. The PBM for the state ran some numbers. And of course, the numbers they left out are all specialty drugs, which, and y'all may, somebody in here probably knows this better, but 2 to 4% of what's being dispensed, 40 to 50% of what's being paid for. And so PBMs have found a way to monetize patients who are battling, the most serious diseases. And they found a way to monetize that and manipulate that.
Right. The fox is in the hen house here.
Literally.
Yeah. I can't let you leave without talking about Fight Back, our bill with Representative Jay Gotchenclaus. Representative Clark mentioned about closing. Our hospitals in Georgia are closing. Our independent pharmacists are closing. And because I've been around a long time and been sick most of my life, to me, my independent pharmacist is critical to my entire team, my healthcare team. And they are not able to sustain themselves. Tell us about that and why this is such an issue.
Yeah, and what I would say is so much of sort of the PBM practices and their impact on patient care acts oftentimes in more than one place. So there's massive issues with how it acts on patients and driving their costs up, depriving them of choice, having them pay more out of pocket. At the same time, it's really detrimental for providers as well. And independent pharmacies are probably some of the most, some of those that are hit the hardest, right? When you're looking at drug pricing disparities, when you're looking at their ability not to fill brand name medications because they're being steered, maintenance medications because they're being steered. And so Congressman Auchincloss and Harshbarger's bill really looks to, in large federal plans, right? It really looks to kind of rewrite those wrongs, take the pen out of the PBM's hands so they're not able to manipulate drug prices, they're not able to steer patients, and they're not able to favor their pharmacies and their kind of specialty networks over retail community pharmacies as well. So, and it was really important, I think, to both Auchincloss and Harshbarger that this legislation have material benefits to patients. And I think it does, right? It's by far the most aggressive bill ever introduced at the federal level in terms of giving patients their choice of pharmacy. It also looks to do something that you all have worked on and done just wonderful work on here in Georgia, which is forcing PBMs and insurers to share savings with patients at the counter. That's a really big deal. So there was a study, it was a MedPAC study. And by the way, what I would say is up until probably 3 or 4 years ago, so much of what we knew about pharmacy benefit managers was anecdotal. It was pharmacists sharing their experiences and patients sharing their experiences from a narrow perspective. But you've got entities like Global Healthy Living Foundation, 3-Axis Advisors, and now even federal agencies, Office of Inspector General, Government Accountability Office. There's more and more data that's coming out. And MedPAC did a report that, lo and behold, this came out June of 2023, and lo and behold, guess what? Medicare Part D. PBMs are paying their vertically integrated affiliated pharmacies more than they're paying non-affiliated pharmacies. But they also identified, and I want to be really careful because to Dr. Popovian's point, they're not just rebates anymore. I'm going to call them discounts just for the purpose of this conversation. Concessions, right, better words still. But what they found is, and keep in mind, federal law, U.S. Congress almost explicitly says that Part D beneficiaries are supposed to get the benefit of the negotiated discounts, the negotiated concessions. That's what federal law says. Well, so what this report uncovered is there were $50 billion in pharma price concessions that didn't get passed to patients at the counter, right? So essentially they overcharged America's seniors to the tune of $50 billion. And so this bill would do very similar to the legislation that you worked on, require at least 80% of that to be passed back to patients at the counter, right? Which would represent a massive savings. It's something that we're really excited about. And again, like just if you take that number alone, 80%, that's $40 billion to see, lowering drug costs for seniors at the counter.
Just to be clear, some of this legislation we could not move like we needed to in Georgia. So as advocates, we're very excited that there's legislation at the federal level. And we are supporting this legislation because in Georgia, there was too much politics in healthcare to get this passed at our level. This should have been passed last session, and it was not. The rebates issue, the concession issue should have been passed, that this money was created to help the financial burden that patients have, and it was not passed. So we're grateful and want to support you at the federal level to make sure that this happens. Although we know it's got to trickle down to our state, because in many states, they don't care what the feds pass. They want their own legislation, but at least it'll be a push for us to be able to get more done under our dome. Do you have any last advice that you can give us as advocates here to help and move this issue so that patients can have the access that they need, affordable access?
What I would say, and it's always like the folks in the room probably don't know to hear it because you're the folks in the room, right? But like never underestimate the power of your voice. I have seen hearings where there'd be, 6 or 7 insurance lobbyists lined up, saying what they usually say, right? And I've seen one patient come down and literally suck the oxygen out of the room. And when that was over, it was like, this is done. This bill is moving this committee, right? Patients are what move significant healthcare legislation. And it again, like I think most of the time, not always, but healthcare issues, patient access to care issues, and patient stories, when done the right way, really have the ability to be bipartisan, right? And we've seen massive support for things like PBM reform on the steering issue in 2020, where Democrats and Republicans worked really, really well on that issue together, and there really weren't politics. But it starts with the patient stories, and the stories that you'll have to tell are so powerful. And I just think that's what's gonna shape change and continue to shape change.
Thank you. I did not pay you to say that, but that is exactly my call to action for everyone in the room, is to please share your stories with us. It is making a difference. It is the only thing sometimes that will make a difference under the dome, is the impact of your story, and definitely for children that are affected by this. We know what an impact that has. Any other closing comments that you have? Representative Clark?
No, I mean, I think that I appreciate this, and I appreciate that last call to action. That's one of the things I teach in my social policy class, is that my colleagues in the state house and in the state senate, they are not experts on healthcare. They are not experts on pharmacies. They are, a lot of times they are experts in whatever they do when they go back home, whether that's farming blueberries or peaches, or, they're small business owners or things like that. A lot of times the bills that come before them are, they have a very rudimentary understanding of these things. And so it is your stories, your lived experiences, your perspectives that really can move the needle, because they don't have any other knowledge outside of what people are telling them. And so, yes, the lobbyists will come up there and tell their side of the story. They need to hear from the patients as well.
Greg, any last minute comments for this group?
I think just to echo her point, it is unbelievable to me. I remember one of the first things I learned being at the Capitol, how many issues representatives and senators deal with on any given, it is mind-boggling, right? There are interests there for banking, for computers, they're chicken farmers, they're animal advocates, there are, right, like name it. It is nuts. And most of them don't have expertise in healthcare. And just as a patient, think about how difficult it is to navigate this complex web. And then you go down there with 100 voices in your ear. And I'm not kidding, literally sometimes over 40 or 50 insurance, PBM, and managed care lobbyists who are all, you know, in there also talking in folks' ears. And so what cuts through that noise, again, is you all engaging and being consistent and leaning into organizations that fight with you. And again, I'm not over exaggerating when I say, you know, if Dorothy walks in the room, folks are getting nervous, right? They don't want to see you walking in a room, certainly, right? Those insurance lobbyists.
I want to see her.
And then just engaging and sharing stories. You never know where that goes. You know, we were planning a really big PBM reform bill in 2019, 2020. And honestly, you know, frankly, the copay accumulator issue was not squarely on our radar, right? And Heather came to us and, you know, educated us about the issue and some of the representatives about the issue. We heard from some of the patients, and that was a catalyst, right? Had there not been an advocate to come in and speak up for that, we would have missed it, sadly. I wish I could say we wouldn't have, but we would have missed that. And so just making sure your voices are heard and knowing, because I know it can be so demoralizing, but again, and this isn't everywhere, but in Georgia, you all have won more than you have lost. And even when a bill doesn't pass, it can still be a step forward. You guys worked really, really hard on that rebate issue. I always say this, it's hard to pass any bill, period. You could try to pass a bill that says puppies are cute, and that bill's probably going to die, as uncontroversial as that is, right? And now you're talking about running legislation against amongst the biggest companies on earth. And I'll tell you what, maybe that didn't pass last year, but they were worried, right? They were worried. And it was close, and you build on that too.
Thank you. Thank you both so much. And thank you for serving. I appreciate that so much. And thank you for all that you do. I couldn't be where I am without people like you.
Thank you.
Hello, my name is Salathia Deloach, and I'm from Savannah, Georgia. I was diagnosed with lupus in 2001, right after I graduated from high school. I was preparing to go off to college, but unfortunately, instead of going off to college, I was admitted into the hospital. I stayed in the hospital for approximately a month and a half, and during this time, I unfortunately lost my insurance, of course, as a result of me not going off to college. My parents attempted to request some type of financial assistance for me to remain in the hospital, but unfortunately, they made too much. And I was only 17 years old, and so therefore I did not qualify either. And so I was shortly after release from the hospital where with no insurance, I was going to doctor's appointments and my bills, they mounted up, therefore ending up, unfortunately, on my credit report. Bringing you up to current standards, I currently am employed. And although I'm employed and I have insurance through my employer, there's a lot going on right now with the insurance in our country. And I go to a specialist as a rheumatologist, and that rheumatologist is no longer my insurance is no longer accepting that rheumatologist. So therefore, I'm in the process of looking for a rheumatologist. So that means I would be going to, if I do go to that doctor, I will be going to that doctor and it not being covered under my insurance, unfortunately, leaving me with another cycle of mounting bills. And so I thank you all for the work that you are attempting to do, just for simply listening to us as lupus warriors. And I hope that my small segment here would be of some help and to cause some change within the work that you are doing. Thank you.
Hello, my name is Christopher, and I live with over 15 chronic illnesses. The two most prominent conditions that I live with are lupus and chronic kidney disease. Lately, I've been dealing with fainting spells as a result of my kidney disease, joint pain, muscle aches, GI issues, and of course, fatigue. I'm currently taking 4 different specialty medications that require prior authorizations through pharmacy benefit managers. Recently, my employer enrolled us in a different insurance plan. Taking a proactive stance, I contacted my pharmacy and my doctor on day 1 to let them know that I was changing insurance plans. Even though my doctor quickly sent a prior authorization to the PBM responded saying that the medication was not in the formulary. My pharmacy and my doctor quickly told me that they would work on it because the other medications do not work with my body. It took over 45 days, 2 prior authorizations, and hours upon hours on the telephone with the PBM before the medication was authorized. I went without the medication for that period. After receiving the authorization and an order was shipped, I spoke with PBM over and over again to find out the patient assistance program was applied. I didn't want to receive a $1,700 bill. They could not give me an answer. Finally, they told me that my medical insurance was paying for the medication, whatever that means. I never received a clear answer, and this has caused me a lot of stress.
Hello, my name is Chandra, and I have been suffering with this horrific disease for about 34 years now. I was diagnosed with lupus in 1990 while serving proudly in the United States Army. I was diagnosed with discoid lupus, which transitioned to SLE. Although I have this disease, I try and be the best version of myself. I am a mother to my beloved daughter, Sanjay, who unfortunately suffers from many autoimmune diseases as well. I am a nurse, but most importantly, I am an advocate for the lupus community and their families. Being diagnosed at such a young age was not only hard and difficult to maneuver, but it was also very confusing. You see, back then, there was not much information about lupus, and I was so very young with everything to look forward to. Throughout my lupus journey, I have encountered several situations that have concerned me with my health care, including the doctors that prescribe the medications. You see, I honestly don't think they understand how they contribute to our care and how it affects us, not only physically, but in many ways, with those brief 15 minutes that they see you every 3 months. I know most people still look at us and see warriors managing in society, that this disease, but it can have so many attacks on our body, and any part is not left untouched. It makes it even more difficult to live. Currently, I am living with lupus nephritis. Yes, 3rd stage renal failure, and that is very frightening. Not only because of what it brings, but the costs that it brings. There are many assistance programs out there that I have taken advantage of at one time or another. But honestly, I don't think it provided all that I needed, especially being disabled with limited finances. With all the money that we have raised for lupus research throughout the years, by now, not only should there be a cure, but at least more affordable healthcare for all. I know so many warriors who are trying the new medications that have become available in the past few years, but the cost of them can be unfathomable. My advocacy efforts is not only for us, but for generations to come. So let's stop lining the pockets of big corporations and let's focus on what really matters: people not suffering daily. We don't want to let lupus patients live, but we want to make them thrive without lupus. Managing our illness should not have to be this hard. It should not. Insurance companies are only concerned with the profit, while patients are worried about living their lives. My name is Chandra. Thank you for listening.
Thank you all for being here. So we want to start by asking you, Melissa, how has innovation in healthcare improved patient outcomes and quality of life?
Well, we've heard it. Thank you. Well, we've heard it today. I mean, Shannon, I was particularly touched by your journey, the number of innovative therapies you were exposed to, but they weren't successful, right? There were 2 or 3 that were successful for you. So this whole issue of personalized medicine or precision medicine is so very important. And that's part of innovation. That's where Pfizer has moved to, having more personalized medicine. But that costs money and it sometimes doesn't work in a particular patient. So innovation is something that's not precise science, if you will. We want to make sure that there's access for everybody to everything, because one size doesn't fit all. I remember when I first started at Pfizer, I was told, look, we want to make sure that the patient-physician relationship is protected. So the decisions about healthcare should be made, the innovative decisions about healthcare should be made between the physician and that patient. And nothing should interfere with that. No insurance practice issue should interfere with that. I mean, certainly as we think about biologics, therapies, of which I'm sure we'll hear more about when we talk about cancer, those innovative therapies have allowed someone to have cancer 3 times repeated. Congratulations, by the way.
Yes.
That's really great. But that's due to innovation. And so we want to continue to have an innovative environment. Frankly, the U.S. has the most innovation when it comes to pharmaceuticals, and it's because we have an open environment and need to protect that, but we also need to make sure that there's access to the care. So what's the value of having the innovation if no one has access to it?
Absolutely. And so, Lynn, Georgia Core works to bring cancer clinical trials to hospitals and practices throughout the state. Mm-hmm. Why is it important to put these trials in people's own backyard, and how do these innovative trials contribute to patient outcomes?
Thank you very much. Yes, Georgia Core was founded 21 years ago, and we were founded through Governor Roy Barnes at that time. Some of you may remember that tobacco settlement funds came in. Did you? Thank you. We appreciate it. And Georgia actually still receives about $148 million a year from tobacco settlement funds, but only 9% of that goes to cancer, although tobacco causes many, many cancers. And so we advocate on that quite a bit. But as I talked about clinical trials, it's so important for patients throughout Georgia to have access. And what we work on so much is access, especially for our rural and our minority communities, because so many people do not have access to the cutting edge, innovative clinical trials that could either save their life or save someone else's life as a result of that. So I'll tell you my story. When I go out and speak to people, I say, I'm Lynn Durham, I've had cancer 3 times, and I would not be alive today if it weren't for clinical trials. And one of those, my latest cancer, is chronic myeloid leukemia. And there's several years, 30 years ago, there was a clinical trial for a drug called Gleevec, and Gleevec has totally changed. So now it truly is a chronic disease. 25 years ago, I would have died of this disease, no doubt. Now I'm living a normal life with a chronic disease, and it makes a huge difference. And that's what so much of these innovations, so much of the work we're doing on clinical trials, so much of what the pharma companies and the bioindustry folks are doing is finding things that it may not cure cancer. We certainly hope it will, but it's elongating lives. It's letting people live quality of life as they live the rest of their days. And so we work on that quite a bit. Lastly, I just want to say on staying at home and getting these clinical trials throughout the state, patients want to be with their support systems. They want to be with their families. They don't want to necessarily, if they're coming from Bainbridge, Georgia to Emory for or Northside or wherever, they want to be with their people and have the comfort of home. It's so important to get these clinical trials to them, not so they have to come up here. It supports their quality of life. And so we continue to work on that every day to make sure all Georgians have access.
May I add to?
Absolutely.
I just want to say it's to this whole issue of having the clinical trials in the communities where the patient lives is so important. We saw that when we were working on COVID-19 clinical trials. I mean, we knew that African Americans and Hispanics were being disproportionately impacted by the disease by COVID, but the clinical trials weren't taking place in those communities. So we activated our partners through the Multicultural Health Equity Collective and identified, where should we place these clinical trial sites. So you're so right. They want to be in their community, but people want to participate in clinical trials. But they don't want it to be a burden to them. So transportation, all of those issues are key. So just wanted to add that piece.
And I'd like to add a personal note. My son was diagnosed at the beginning of COVID with the rare kidney disease. And I was like, I will quit my job. I'll fly wherever. I'm not kidding you. I was like, what do we need to do? So it wasn't that we had a barrier in our family. I did not really learn about how many people had the barriers. Just living in Atlanta, for example, put us close to CHOA and Emory. And I'm like, this doesn't make sense. So because of COVID, my son's treatment came into the home. And his nurse became such an important part of not his physical health, but his emotional well-being. So thank you all for talking about the importance of reaching people. So Leanne, as I mentioned, my son was diagnosed right to turning 18. So pediatric research and clinical trials is really important to me. I can make sure that pediatric patients and their parents are included in the device and drug development process. Tell us what that looks like.
Yes. So when we talk about innovation, as a patient, you know so much about your condition or the device you live with or the drug you live with. You know more than anybody else, even a doctor who's been trained, because you live it every single day. And so it's really important to include the patient, and I advocate for pediatric patients and their caregivers to bring them to be a part of the discussion. So whether it's the ideation of a device that's needed because they're hacking things at home to make things work, or just being able to be a part of the whole, say, research process. So let's say Pfizer, which is one of our sponsors, by the way, thank you. So let's say Pfizer is going to start a clinical trial. What our kids will do is they will work with Pfizer on the assent and consent forms to make sure that it's understandable by someone of that age, that it makes sense, that there are things in there that aren't, looking at the protocols, making sure there are things in there that aren't showstoppers, or, we don't know how kids are going to react to being in the clinic all day for 8 hours one day. How can we make that better? And so to get input from the kids and families before you even start a clinical trial to make sure that it's going to be something that works for them as well as we can do it and make it not a burden on them. And so that's one of the things that we do so that companies will come to us and work with us, and we will share with our network. We have our members are kids and their families. We have chapters, 40 chapters around the world, and we're condition agnostic. So we will take any child with any condition. Probably 50% of our kids have a really rare condition because they don't necessarily have another place to go. But we will have industry work with our kids. We also send our kids to the FDA every year. We have a relationship with the FDA. And just in September, in a couple of weeks, one of our moms and her son are going to go talk to the FDA about what their experiences are like participating in a clinical trial. So it's really all about giving the kids and their parents the opportunity to share what it's like to be them, and then helping the people who are in healthcare, whether it's a clinician, how do you interact with me? Whether it's a researcher, when should you approach me? Or somebody building a device, would you ever use it this way at home? Does this fit into your school routine and your aftercare activities and those types of things? So that's what we do at ICANN, but it's always possible to bring in those patients, and I would highly recommend that at any step of the process for development or research that you bring them in and listen to them because they are the experts.
Thank you. And Melissa, can you provide specific examples of innovations that have made significant impact on patients' lives?
Thank you. I mean, we'll talk about a few, but I want to also talk about just the value of access in innovation. So telemedicine to me, has made a significant difference, especially for those living in rural areas those who don't always have access to the physician, to the nurse. So especially during the pandemic, and telemedicine played a huge role in making sure that patients were still accessing care. And I know as we've done the questions, access to care is the key. If you don't have access to care, you don't have access to the innovation. So I really want to point that out, but I also want to point out in terms of immunotherapies, where we are with that, and then cancer care is just so amazing. So that's a really another great example of how innovation has improved a quality of life, and you've had longer life because of it.
Absolutely. And so, Lynn, there have been many advances in cancer treatments over the last decade. How have new medications changed the way cancer is treated, and how have patients benefited from these new treatments?
Well, I want to follow along what both Melissa and Leanne said, that, really access to those is certainly key, but so much has been done in the last 10 to 20 years. And over even just last year in 2023, more than 40 oncology drugs were approved by the FDA. There's so many drugs coming out every day. And what they're doing also, these drugs, what's so miraculous and wonderful, it's not the toxicity is coming down. So you can have these chemo treatments or immunotherapy or targeted radiation or other new ways of delivering these treatments that are really impacting people and the quality of their life. And so, so much of it was scattershot for so long. You're just trying to kill the bad cells and you're killing the good cells while you were killing the bad. And now it is so much more targeted with immunotherapy, with targeted radiation. They have vaccines now. So now they're developing vaccines that either can be preventative, like an HPV. Hope everybody in here and their children have got an HPV vaccine. And then, but they're also for after you have cancer, as a way to treat cancer, there are vaccines. So there's so much happening in this space. It's hard to keep up. Our doctors tell us all the time. We have many medical oncologists on our board of directors, and they tell us all the time, we cannot keep up with all the new treatments that are coming out. That's a good problem and a bad problem, because there's so much happening, but it's hard for them as professionals to see patients and to keep up with everything. But I have to say, the future is so bright, and they're looking at ways to maintain people's quality of life while trying to give them a longer life.
Thank you. And Leanne, how is using real-world evidence helping to bring technologies to rare disease and pediatric patients faster?
Yep. So real world evidence, if you haven't heard of it, is really just saying there's so many people out there who have a rare disease who are using a drug or a device, really a drug typically, that is not what the drug was initially developed for. And so the FDA doesn't recognize it as a treatment for that drug. Also, if you're looking at pediatrics specifically, so many things are not tested on pediatric patients. And so it may work for adults. Pediatric patients are really different, but they just kind of scale the number down on what they're using on the kid, right? So if you're a child or somebody with a rare disease or both, you're probably using things that have not been approved by the FDA for that purpose. And so what real world evidence does is say, okay, we've got all of these people out there who've been using this drug for this condition. Let's look at all of that information and say, we can make an approval based on that instead of doing a clinical trial. So now you don't have to recruit for a clinical trial. You're actually interacting with the people who are most going to use this technology or drug. And you also are then taking into account any kind of diversity, because naturally you're going to have a crowd who is meant to take that drug, taking that drug. And so you're hitting the right population. And in addition to that, if you don't have to wait on clinical trials and things like that, then you can look at these treatments and say, yes, they can be approved for this. And so just because of that, you're making things safer because you're really looking at the population who's using the drug. And you're also bringing it to more people faster through the whole process by cutting out a piece of the process. And I think that that's what really makes real world evidence something that, you know, the FDA is really looking at now, something that's really worthwhile. And it also helps with the clinical trial. You don't have to go to rural South Georgia and find the one kid with the problem. He's already been treated with that that drug. And I think that that helps a lot.
Thank you. Melissa, how has technology-driven innovation transformed the patient experience?
I remember when I want to specifically talk about the electronic health record. First of all, having all of your health information in one place. I mean, Dorothy, Robert, you all remember when we were always advocating for having all the information in one place. So just the innovation of electronic health records, I think, has definitely improved healthcare. And then you can do so many things with that, synchronizing your medication. And so, your patient can go to the drugstore one time a month instead of multiple times a month. Certainly when we also think about technology, we think about these wearable devices. I mean, we can now see our heart rate and monitor our blood pressure and all of these things. That's innovative therapy, innovative technology that has, I think, made us a healthier society, and it definitely has made us much more aware of things. Now I get to see what my doctors are really thinking about me because they put in the notes. So it has, I think, has been a really great thing for patient information so that patients can take control of their own health care.
Yeah. I also think that's super important for rare disease patients. If you're taking multiple medications that for my son, he could hardly pronounce, and then you have to go to the ER and he was able to pull up his record right on his phone, and so I completely agree. So thank you to everyone who advocated for those electronic records. So Lynn, why is diversity and equal access important in clinical trials, and what is being done to change the way trial protocols are written to be more inclusive and to increase access?
Absolutely. Well, as we all know, COVID taught us a lot. And one of the things that COVID taught us very clearly was that people did not have equal access to treatments and medication and clinical trials. And so we know that most clinical trial participants are white men. Well, that tells us what these drugs do with white men. And so we really need to make sure that more women are involved in clinical trials, more African Americans. We interviewed a wonderful woman who's a breast cancer survivor, and I loved what she said about she participated in a clinical trial. And when asked why, she said, my mom always told me not to take someone else's medicine. And if Black people don't go and participate in clinical trials, do we know that medicine is made for us? I don't know. And so that really struck me. And so we work very hard to get a very diverse group of people in clinical trials. But what's happening with the protocols now, and Leanne touched on this a little bit, is because it's so hard and so people, again, want to stay at home, instead of having everybody come to Atlanta to take part in a clinical trial, why can't we decentralize those trials? Why can't they be created and written so that you can do a blood draw at home? You can do a telehealth appointment. You can do other things. A nurse can come visit you at home instead of you coming in. I've heard so many stories of patients who've come from rural Georgia, literally driven to Emory and gotten so flustered and so upset by the traffic, by the parking, by everything having to do with it. They've turned around and said, I'm out. I'm not doing this. And so it's so important to find ways to write these protocols to get people where they are in their homes. And then lastly, I'd say exclusion criteria are also being examined. So many times when you have a clinical trial, you look at so many criteria of who can participate in this trial. Well, a common exclusion criteria is hypertension. Well, a lot of Black people have hypertension, and so it excludes them immediately from being part of clinical trials. Do we need to have that exclusion? So they're really, really digging in and looking at all this. It's just been done this way for so long to say, does it still need to be done this way? And most of the time it doesn't. And we need to be innovative about what we're doing. So that's what's happening in the way of looking at different clinical trials and how we can make them more accessible to more people.
That's so important.
Representing a pharmaceutical company, we definitely are open to other ideas because we are doing the decentralized clinical trials and trying to make sure that the patient doesn't always have to go to a big clinical trial center. So we welcome all ideas. In fact, at Pfizer, we have a group of people totally dedicated to making sure that our clinical trials are diverse. And that was the lesson that was taught to us by COVID, that really if you ask the person, a diverse patient, they will participate in the clinical trials, but you have to make it accessible to them. So this thought that, diverse patients don't want to participate in clinical trials is just such a misnomer. They do want to participate, but they need to have access to those. And like you said, those exclusion criteria have been standard.
Mm-hmm. Yeah, and I'll just add on top of that diversity includes pediatrics. It includes the young patient. And in addition, when you said, don't take a drug that's not made for you, I think about all of our kids, right? Drugs aren't made for them. They are excluded from these clinical trials because they're a protected population. But then are we really protecting them by not testing these drugs out before we give it to all of them? So I think there's a lot of ways to look at that.
Leanne, we had a backlog because we actually did COVID-19 clinical trials for pediatric population. Kids were lining up telling their parents they wanted to be in the clinical trial. So kids they really get this.
They do. Yeah. Kids want to participate. I hear that all the time from all of our kids. They are ready to participate. If it's going to make, and they'll tell you, I love kids. One reason they figure that a lot of these aren't going to help them, right? Whatever it is not going to be developed in time to help themselves, but they want to help another kid not go through what they did. Yeah. How can you not just absolutely love that about kids and how they think? So they want to participate.
I absolutely agree. I think that there's this idea that they don't want to participate or that they're scared to participate. Children who live with a rare disease are very aware that it can be scary. My son was diagnosed a week before turning 18, and I say to people all the time, for us, that was a blessing because he qualified. Now there's some things that have changed with the study he's in. They are working with children, but he would say even going to events and traveling and meeting patients, it was so sad to him that these children were just waiting for their kidneys to fail. It seemed unimaginable. So thank you all for the work you do. And finally, Leanne, how has innovation in medical devices and treatments contributed to better patient care?
There's so many things that I see between my job and then what I do with ICANN that I'm amazed every day. But one of the groups that I love is when a parent or a child themselves who has been living with a problem their whole life sits up and says, you know what, I could do this better. And they come up with a solution because they couldn't do it that way at home anymore. And I think it's so amazing because it's something that all kids like that child have in common. That's, a struggle for the parents or the child to do and live with something at home. And so when they come up with something, we try to promote all of our kids' innovations through ICANN. And even with what we do at Georgia Tech, I talk to a lot of parents who come and say, hey, I have a kid, we need this. Can you all help? And to the best of our ability, we try to. But, even things, somebody talked about taking back control a little bit of your condition. That's another reason why kids will participate in ICANN or participate in a clinical trial. The disease is maybe taken a lot from them and not let them go to school like they wanted to, not let them play with their friends. If you can take it back by saying, I'm going to help beat this, right? Do whatever I can. But also thinking along those lines, like we were working with Children's Healthcare of Atlanta, and they were like, how can we help kids with autism get more used to an MRI without having to be medicated because it's so overwhelming for those kids and a lot of adults too, right?
Yeah.
They're not fun. And, our researchers went in asking the kids like, well, do you want bright colors? Do you want stickers on the wall? Do you want it to look like a pirate ship? And what they came up with was just multicolor lights in the room, and the kid had control over what light was being shown at what time. And it just kind of gave them that little bit of control to entertain them and help them think about something else. So technology doesn't have to be, developing the next cancer cure, right? I mean, this is just a light with a remote control that the kid could use in an MRI system. So I think, just because it's not big and flashy doesn't mean it's not impactful to the people that it's doing things for.
And I was just going to say, clinical trials are so much part of the culture in pediatric cancer. 80% or so of children that have cancer undergo or participate in clinical trials. In adults, it's 5%. And so we need to make it more of the culture in adult cancer, because pediatrics is showing us the way. They've done incredible work and they're showing us the way, and we need to do better.
So any final thoughts from any of you on the panel?
I think most of the speakers have said this today, but advocacy is so key. So this is a really great opportunity for us to learn. Now we need to put what we've learned into action. I know I may be speaking to the choir, but go tell one person, go tell another person, because we really need people down at the state capitol. I think one of the speakers said, a patient will change the whole vote. We will have we know we're going to lose the vote, but patients testifies, and that changes the vote. So we really need the activism that comes with having the education.
I'll say for kids particularly, listen to them. Just because it's an 8-year-old standing next to an adult, the doctor shouldn't be talking just to the adult. The kid will tell you, I'm the one living with this. I'm the one going through it. Talk to me. And I think that's true through the whole spectrum of research and development. You should be willing to listen to that child. It doesn't matter, that they're young. And a lot of people just instantly discount that a 10-year-old, can't control the room with a talk. I've seen it. 400 people, a 10-year-old on stage telling their story, and everybody has their cell phone down, and everybody is looking at that kid and listening to them. And it's really just remarkable. So, don't ever discount somebody out.
Oh, great. And I'll follow along a little bit with Melissa said. Like I said, I was in government and politics for a long time. And just out here a little while ago, Senator Brandon Beach walked in and said, hey, my brother has pancreatic cancer, and I'm really passionate about this. Find the people who have experience in healthcare and in their families having a problem. I had a legislator whose wife had colorectal cancer in her 20s. And so those are the people who really understand and can help you communicate what you need to communicate and be your champion. And so find those people that have had those personal experiences and who are willing to share that and help you find a solution.
And I'll just add one more comment onto that. So you can find those people at organizations like ICANN or all of those advocacy groups, right? So these people exist. Quick Google search can tell you where to look, and they're always willing to talk to you to help you understand what they really need.
Yes, I would say for us, I found the advocacy group that ended up helping us understand and connect us at 3 a.m. after diagnosis, because I couldn't sleep just Googling. And my son has traveled all over the United States and even to Ghana to share his story and to encourage young people to take control of their care, in the sense of, knowing that you are at risk of different diseases. Just because you look healthy doesn't mean that maybe something else is not going on. So we have a few minutes if anyone has any questions for the panel.
So with innovation come, good things, but there's also new challenges. I mean, certainly in the pediatric space, we see kids living longer. This brings up a host of new challenges. Certainly in the oncology space, there's a difference between, I think oncology's kind of been a silo, rare disease has been a silo. With innovation and all these drugs that are coming, who's looking at and keeping track of the new challenges and problems? And I speak from a personal standpoint. My father had hairy cell leukemia about 8 years ago, now has ALS. Now, We don't know that it was caused by the chemo drugs, but certainly there could be a correlation. It's just too odd in our family that there's no history of it. But what concerns me most is who's watching this, because we know oncologists don't talk to neurologists or neurodegenerative. So just curious for your thoughts on that in the innovation space.
I think it's a great question. I told you all I had 3 cancers. I had thyroid, breast, and chronic myeloid leukemia. I also do not have proof that the treatments from the previous cancer caused my leukemia. I don't know that. I don't know it didn't either. And so I'll tell you that I don't know who is watching that, to be very honest with you. I think university researchers, and I don't say that just because Leanne's beside me, but I worked at Georgia Tech for 25 years and I saw the incredible work they do. They take a more holistic view than the doctors do. Then they're treating their patients. They're kind of in their silos, even to the point, get real personal today. I went and saw a shoulder doctor today because I'm having shoulder problems. It's like, why wouldn't you just go to somebody just in orthopedics? No, they're so, targeted now that it's a shoulder expert, and it's so happening that way with diseases as well. And so my only answer, and maybe Leanne has more to this, to me, the academic researchers are the one that are looking a little bit more at cause and effect.
May I add a little something? The pharmaceutical companies are doing post-clinical trials. So we do, the clinical trials don't stop at phase 3 clinical trials. There are clinical trials after that. We always are open to receiving information that opens up, I don't want to call it investigation, but they're looking into, is there some causation. So reporting side effects is so very important when you're, to the company who made the drug, because that does trigger us to do more. But we do post-clinical trials, and the FDA asks us to do post-clinical trials. So I think I remember around the COVID-19 vaccine, everyone wanted to be assured that those clinical trials were still taking place, which they are. So that's why I know. But if there's anybody in the audience, Robert, is there anything else that we could add to that?
What you guys all talked about, which is having like databases to manage the entire patient. And that database, by the way, the only caveat I would put on the database, that it should be accessible to all healthcare professionals. Okay, so because what happens is that a lot of times that electronic health record is only good for people who practice within that system, and this patient may be seen by somebody else, and that information required by that somebody else, that healthcare professional. So,
And
I have a personal story. I mean, I have a friend of mine who has autoimmune disorder, 49 years old. She needed a shingles vaccine, which is recommended by the CDC to be given by anyone, by pharmacists, but 90% of shingles is given by pharmacists. When she went into the pharmacy, they weren't willing to give it to her because there's no way they can prove that she has autoimmune disorder, because she wasn't getting her medicine from that pharmacy. And that pharmacist is like, yes, I can't take your word for it. And the physician was not giving it to her either, the primary care, because she was being treated by a specialist and he doesn't have access to that information. So there's a lot of things that we can do to circle the patient and help them better understand their disease state.
And I just want to add a comment to your original question. So one, I totally agree with Lynn that there are academic researchers who kind of look at that bigger picture, but also patients speaking up. So if you're a part of a patient forum, say on Facebook, so one of my conditions is sarcoidosis. And so I'm active on the Facebook group. And there's been things that we've learned from each other that I've been told by doctors are definitely not related to my condition. And yet all of us online have it. So I think that there are things that if you can talk to others and learn from each other, then that gives you a voice to stand up and say, you know what, I don't think you're right on this. Or that's the real world evidence. Exactly. But yeah, so I think that it comes from you too.
So, do you guys have any advice or suggestions for patients when they're kind of stuck in those situations where, like, I'm a biochemist. I have a PhD in biochemistry, cell and developmental biology. I cannot tell you the number of times doctors have said, "Okay, Dr. Google." And I've had to reply, "No, my name is Dr. Fagan. I worked hard for my PhD. I understand this stuff at a very basic level. But because I'm a patient, I'm always dismissed." Doctors, I mean, I feel like medicine really is an experiment between the doctor and the patient, where the patient is the one doing the experiment and the doctor is really the advisor. But that's really not the relationship or how it's set up. Do you guys have any advice or ideas of how we can get that to change or improve that? Like, how new research and new things come out is great, but like, some things we can learn as patients, but if the doctors aren't accepting our knowledge and they're not doing the work themselves, we're kind of stuck.
Yeah, so I'll say one thing that we're doing with ICANN is not just giving kids the opportunity to talk to industry and the FDA and researchers, but we actually have created kind of a whole educational curriculum for them that helps them feel more confident, lets them understand that they should be heard and listened to, and to speak up if the doctor is dismissing them, because that happens all the freaking time. So we're trying to really raise that child who also has knowledge, like what a clinical trial is and what all of these different pieces of a clinical trial are. And so that's one of the ways that I hope that we can kind of raise the next generation to know that they should be listened to and make doctors accountable for that. But I also think that as the paradigm shifts from it being all white males who are clinicians to, you know, women and people of color and whatever it might be, they're more likely to listen, I think. But for me personally, one of the ways the doctor put me on calcium, which is actually a no-no for my condition. I'm a researcher. I'm lucky that I'm a researcher by nature. So I get diagnosed and I'm like looking up everything, probably like you did, right? Yeah. And so when he was like, "I need to put you on this because I'm putting you on this other drug," and I was like, "Okay, look, I am not a doctor. I 100% admit that, but I have read that that is not good for me in this situation." And before I got to my car in the parking lot, he called me and said, "You're right. Don't take it." So I think sometimes just, you know, admitting, I'm not the doctor, you have the education, but look, here's what I found. Please double check it before you do this to me.
Have you found that like those, like the ICANN, where you educate the patient, has that improved like their patient compliance, their health overall, and stuff like that?
We actually don't keep track of what their health condition is necessarily, but I can tell you when I put 100 kids in a room and they're being asked questions by Pfizer or whoever the other companies may be, you'll have some kids who naturally are outspoken and they want to speak up. But then the other kid may be sitting in the back, because that was always me. I see them and I see them change and I see them start speaking up. And so I know, and then they get it. And then when we have them do surveys, we bring the changed product back to the child to say, does this do what you wanted it to do? Does it make sense now? Did they listen to you? And if they say yes, then that's what we want. But bringing that information back so the patient can see how things changed because of what they told you is a really important part of the process.
The only thing I wanted to add to your question was there's also the physician education that's involved. I mean, certainly the Medical Association of Georgia participating in their meetings, maybe getting that as a presentation there. Georgia State Medical Association, which is the African American physician organization, talking to the medical schools. I really think you should get them when they're in medical school, right? So having that as a course, you should be teaching that, you know? So I think that those are other ways. And certainly I know that the medical schools I've worked with have been open to different ways of teaching their doctors to be more sensitive to patients. So I would definitely recommend talking with the medical schools and seeing maybe that can be part of a curriculum or something like that. Yeah.
100% it should be part of it. thank you everyone so much. I feel like we could talk about these things for a really long time, but our session has ended. So thank you all so much for joining us today and for your input and the work you do.
Thank you to those amazing panelists. We are so fortunate to have y'all here with us today, and thank you so much for your time. Go ahead, Melissa. Let's see. And then now we're going to start to wrap things up with a call to action from Dorothy, and I will let her take it from there. Thank you.
I'll make this very quick. I think you already know what I'm going to say. We learned a lot today, and I thank everyone who participated and all of you for coming. We always have a call to action because we're advocates. So my call to action is we're going to be calling on you. We're going to be calling on you to call your legislators, to do an op-ed, to do an interview, to maybe write a letter and let them know what's important to you. Why we need to change the system, why the system has to work better for the patients, and also in upholding not only innovation, but the patient-doctor relationship that has been robbed from all of us because there are too many people involved now in the process. So we just ask you to be aware that we'll be reaching out, and we hope you will join us. We have other events coming up that are like this. We also do events under the dome to help educate our legislators, and we bring our organizations together so that we have one loud, powerful voice. The patient's voice we learned today makes a difference. We are influencers. When the life sciences and the patient advocacy groups come together, we are policy influencers, and we can make a change to help every single patient live the best possible life. Thank you today for joining us.
Thank you. So I'm just kind of going to close this out. I just want to thank everyone for being here today, particularly our speakers and our sponsors, ARXC, Pharma, the Greater North Fulton Chamber, and Grail. This event wouldn't have been possible without you all. And let me see if I need to thank anybody else. Dorothy, we thank you again. But yes, thank you all so much for being here. And there is another event that this space is hosting that's going to be starting here shortly. So if you guys kind of want to make your way out to the lobby, or beat traffic if you can. But yeah, thank you so much. I appreciate everyone being here.